We begin our program with a welcome address. It's my honor to invite the principal of our esteemed institution, Dr. P.K. Jabbar sir, to address the gathering and set the spirit of this evening.
Madam Secretary, Pradhan Secretary. Good evening, one and all. Respected and great teacher, Raju Babal sir. My colleague, and probably my teacher, Dr. Usha Devi, and other distinguished faculty on the dais and off the dais. I know there are very, very important personalities are sitting in the crowd. Dr. Ghosh is there, Dr. Reju is there, all my colleagues are here. Dear students, I'm extremely happy to stand in front of you because of two or three reasons. All these activities are being conducted as a part of Platinum Jubilee Celebration of our great institute. You know, so we are in the probably we have just finished 75th year, and we have arranged a lot of academic programs, non-academic programs, social programs as a part of our celebration. But this time is a very unique program for today. It's a, I would say, one of the need of the hour for us. See, dignified, certain terminologies are very strange for me, but it's very interesting terminologies. That, of course, is today I was discussing a case with one of my assistant professors in my office. Only one thing is very sure. അരുൺ നാളെ ആരാകും എന്നുള്ളത് എനിക്കറിയില്ല. ഞാൻ ഇവിടെ നിന്ന് ഇറങ്ങുമോ എന്ന് എനിക്കറിയില്ല. പക്ഷെ ഒരു കാര്യം സത്യം. One day, Mr. Chitraguptan will come to your office and he will take you. ഒരു സംശയമില്ലാത്ത കാര്യം. അത് മാത്രമേ ഉറപ്പുള്ളൂ. അത് നല്ല രീതിയിലാവാൻ വേണ്ടിക്കൊണ്ട് നമുക്ക് പരിശ്രമിക്കണം. നമ്മളെ പെരുമാറ്റത്തിലും ആ പരിശ്രമം വേണം. Whatever happens for you in your journey, you may develop some issues also. And one of the real comorbidity for us is the terminal care issues. There are a lot of issues including pain. My topic is, of course, not at all related to palliative care or any sort of specialty of that kind. But I can tell you one thing. Now see, this pain and palliative care system is setting up in a big way. And of course, this longevity is also increasing. That's the reason people are getting a lot of medical problems. And eventually we need to get all this support during our last hours or last days. Another interesting and very, like I said, I want to say, I'm proud to stand in front of you to introduce and welcome the great personalities. Sivasankar sir is also here. Raju Babal sir. When I was looking into the profile of Raju Babal sir, ദൈവം സമ്മതിക്കുമായിരുന്നെങ്കിൽ സാറിന്റെ മുന്നിൽ കുമ്പിട്ട് നിൽക്കുമായിരുന്നു. So great, a very simple man, very, very simple man. Started his journey probably from 1947. Various institutes, medical institutes in our country and of course Kerala. And he's having lot of credentials. Lot means in all sense, lot of credentials. See again, you just see his face. Very simple man. ഏറ്റവും സിമ്പിൾ ആയിട്ട് ഒരു മനുഷ്യനെ കാണണമെങ്കിൽ അതിനു വേണ്ടി കൊണ്ട് just look at his face. So I'm really proud to say that as a principal of this institution, എനിക്കിതിന് ഭാഗ്യം കിട്ടി, even though I'm not an ideal candidate to introduce Rajagopal sir to this crowd. On behalf of entire people of our here and my own behalf, on behalf of the institution, sir, I welcome you, sir, for this meeting. And next we have Dr. Cyrus Parvati. I don't know anything about Parvati madam, but I can tell you one thing. She is one of the very notable personality in this field. Madam, on behalf of entire organizing team and institution, I sincerely welcome Madam to this program. I don't want to say welcome to my own friend, Dr. Hagit Prasad. He is one of the very active member of our organizations and academician, good orator, a good teacher, and as custom demands, I welcome Dr. Hagit Prasad. My colleagues, one of the senior most faculty sitting in the chair of Vice Principal, Dr. Usha Devi. I need not welcome Madam. Madam is a part of organizing team. She is probably a part of this institution in all sense. But just I welcome Madam also to this call. Organizing Secretary, Dr. Pradap. Pradap is a very active personality and is basically a pathologist, good organizer. Dr. Pradapji, I welcome you to this crowd. Very important persons like both sir, our teachers are sitting over here. Dr. Aruna is here. Lot of very dignified personalities are over here. I welcome each one of you to this crowd. My dear students, കുറച്ച് അടുപ്പുള്ള കുട്ടികളാണെങ്കിലും അവരിവിടെ കയറിയിരുന്നു. അവർ വളരെ നല്ല രീതിയിൽ ഇവിടെ ഇന്ററാക്ട് ചെയ്യാൻ പോവുകയാണ്. എൻ്റെ കുട്ടികളെ ഞാൻ തന്നെ ഈ സദസ്സിലോട്ട് സ്വാഗതം ചെയ്തുകൊള്ളുന്നു. എൻ്റെ ഓർഗനൈസിംഗ് ടീം ഈ ഭാഗത്തും ആ സൈഡിലും പല സ്ഥലത്തും നിൽക്കുന്നുണ്ട്. അവരെല്ലാവരെയും ഒറ്റ വാചകത്തിൽ ഞാൻ വെൽക്കം ചെയ്തുകൊണ്ട് ഞാൻ ആരെങ്കിലും വിട്ടുപോയിട്ടുണ്ടെങ്കിൽ ക്ഷമ കൂടെ ചോദിച്ചുകൊണ്ട് നിർത്തട്ടെ. നന്ദി, നമസ്കാരം. താങ്ക് യു.
Thank you so much, sir, for those warm and inspiring words of welcome. So I kindly request you to stay back. Dr. Vishwanathan sir, our DME, has been caught up with some inconveniences and unfortunately will not be able to join us today. Thus, in his absence, I humbly request our principal, Dr. Jabbar sir, to formally inaugurate the program.
Dear friends, see, Dr. Vishwanathan is so busy today because of multiple official issues. In continuation, okay, this program is a very useful. Definitely, this will be one of the best program conducted in this auditorium. There is no doubt about that because it is a drawings are sitting. Okay, with one word, I declare this meeting is open and inaugurated with your permission. Thank you so much.
Thank you, sir, for those enlightening words. We now have a moment of honor and gratitude. I request Dr. Usha Devi ma'am to kindly honor our chief guest by draping the punana. inviting Parvati Madam. Thank you, ma'am, for this beautiful gesture of honor. And now, the heart of our evening, the panel discussion. To moderate the session, I now invite Dr. Arun Nair, sir. Over to you, sir.
A very good evening to all of you. Especially today is an extremely important day in the history of palliative care in India. Because you might have read in the newspapers today morning about a news which has happened in the case of Harish Rana, the first person who has been legally allowed euthanasia. So we'll discuss about the nuances of that issue also as we proceed. So let me introduce the three panel members, and the fourth member will also be joining me shortly. We have here Professor M.R. Rajagopal, founder chairman of Pallium India. He is regarded as the father of India's palliative medicine. And we are extremely lucky to get an opportunity to listen to such an extremely knowledgeable, extremely empathetic, and probably one of the most down-to-earth human beings you can see in medical profession. He is an alumnus of this institution, a member of the 1965 MBBS batch. Then he did his post-graduation in anesthesia. He worked as a faculty member of anesthesia, mostly in the northern part of Kerala Medical College, Calicut, primarily. And after his retirement, he started this organization of Pallium India. Most of his work has been in Malabar, Calicut region to begin with. And later he expanded his work to the capital state of Kerala as well. And we get a chance to meet him. And his autobiography, Walk with the Diary, is a book which every doctor, every young doctor should definitely read. A few copies of the book are made available at the back of this hall. And after this program, you can avail the book, you can buy the book at a discounted rate as well. The proceedings will go to the activities of Pallium India. So with great pride and deep respect, I'm welcoming you, sir, to this panel discussion. The second person in the panel is Dr. Parvati Sundareshan, ma'am. She is a student of the 1973 batch of Trivandrum Medical College. Then did her post-graduation in anesthesiology, worked in health service, then was a faculty member of the Department of Anesthesiology of our own college, retired from our institution, then she worked as faculty in anesthesia in certain private medical colleges. Now, along with Rajagopal sir, she is working in Pallium India in the field of palliative care. With deep respect, welcoming you, ma'am, to this. And the third person is our own P.G. Hariprasad sir, professor of Pediatrics, my teacher. He did his MBBS and PG here, and is now working as a professor of pediatrics in SAT Hospital, Trivandrum. He's an expert in pediatric palliative care. That is what brings him here as a member of this panel. With deep respect, inviting you, sir, for the panel discussion. And we need someone from the students also to make the discussion lively. So we have a very young, energetic, enthusiastic, brilliant orator among yourselves with us, a student of the 2023 MBBS batch, Siddharth Patel will also be joining me for the panel discussion. Welcome, Siddharth, to the house. Rajagopal sir has written an article about euthanasia, passive euthanasia, the terminologies, the philosophy, everything in today's Madhubhumi newspaper, the editorial page itself. Those of you who have the habit of reading newspapers might have read that article, I guess. So to begin with, anesthesiology is a specialty which is very much in demand in modern medicine. A large number of brilliant postgraduates opt for that because Anesthesiology is one of the most attractive specialties from a commercial angle also. And people who specialize in anesthesiology also take care of the critical care, which is very much in demand. But palliative care happens to be a specialty which is not much in demand from a commercial angle. Most of the big hospitals may not demand it or may not employ people also. So I would like you to explain the philosophy of what is meant by palliative medicine and end of life care to this group of budding doctors.
Audible? Thank you, Dr. I don't know. I don't know whether anybody who has gone through house surgery already is here. When I became a house surgeon, one of the things I was mortally scared of was being called to see a dying patient. Because all the clinics and all the teaching had nothing about it. And when I went there, I did not know what to do. Fortunately, some nurses would guide me. One of the most difficult things was to diagnose death. You keep the finger here, and after some time you feel your root part. It was so hard. And actually, Siddharth, sorry, must confess, the patient was already gone and it was a sense of relief. Now I don't have to do anything because the only thing we used to do was give a respiratory stimulant and totally meaningless things. Then possibly in your time, it was not part of the curriculum, but you have it in the curriculum. It's only since 2019. It's there, usually not taught. Dr. Iron at the beginning said everybody goes through this end of life, except about 10% of us who may die a sudden death. 90% of us will go through a prolonged illness. Sorry to tell you this bad news. I just hope it's a long time away. I can see it right in front of me. And one of my fears, he said I was also an intensive care doctor. Intensive care has changed in the last quarter of a century. Till then, it was for people to be diagnosed of any organ dysfunction at that point of time, intervene and prevent dysfunction of other organs and bring them back to life. It did not, till the turn of the century, used to be for dying people. Now, we don't know how the transition happened. Within that short for me, quarter of a century, it has become a place where rich people die. I suspect that about 10 people in this whole audience may be brave enough to think of your own death. I will not ask for a show of hands, which may be embarrassing. If anybody can think of your own death, please tell me later when the discussion time happens where you would like it to be. I will tell you what I want. Dr. Mohan, I certainly do not want it to be in your intensive care unit. That's a great place to save lives in. But in that cold environment, I'll be shivering. There will be no family around me. What would be important for me at that time? It would be the family, maybe a hand to hold, maybe you comforting me and saying, we'll look up to you. Acknowledge me as a person. Does that happen? Only my cardiac output and saturation, everything shown on the screen will get attention. I will not get attention. My family will be able to come in for 5 minutes, will not be able to touch me because I am covered with cables. It is a cruel infliction of suffering that we healthcare providers, health, physical, social, and mental well-being, we destroy health for everyone who dies with some money in the pocket. So the new judgment that came out yesterday clarifies some aspects of a 2018 judgment and 2023 judgment. Sad that we are not creating guidelines that are proper. Sad that the court has to tell us what to do, but that's the way it is. So this judgment lays down some procedures which are unfortunately much too complex, but says that at the end of life, I and anybody who dares to think about it, you have and I have a right to a dignified end. For that, I have written my advance medical directive, otherwise commonly called living will. I've got it countersigned by a gazetted officer, and today, thanks to the Supreme Court judgment of 2018, that's a legally binding document. Doctors, when I come to you for treatment, I have kept it on the top of my case records, and you now have a legal responsibility to honor that. According to that, my wishes are that I should not be confined to rigorous imprisonment in an intensive care unit at the end of life, that I should be allowed to be with my family. I don't know if I've answered your question, Dr. Happy to clarify anything else.
Thank you, sir. Thank you, sir. We will discuss the other aspects as we proceed. I will move to Parvati ma'am. One of the biggest concerns which students were raising a couple of months ago when we had a session on mental health of medical students was that we as medical students have to witness a lot of deaths and end of life experiences. Most often the house surgeons are supposed to reveal to the patients or caretakers regarding an important diagnosis which could be the cause of death or which could be frightening to the patient or a layman bystander. So how should we break that bad news to a patient, number one? Number two, to the caretaker? That would be the question I would like you to clarify.
Thank you, Aaron. Am I audible? Young friends, please come forward. There are so many vacant chairs here. Please come forward. Don't sit in the back.
Please come.
Come. Backbenchers, please come forward. Can you hear me in the back? Yes, okay, thank you. So, first of all, I would thank Arun for that question, but I would like to correct that term, because breaking bad news, something like a violent term, I would prefer to use that term communicating bad news or communicating truth or truth telling. Have anybody a response to say why communicating truth is important to the patient as well as the family members? Can anyone raise the hand and help me with that answer? Why it is important? What is the difficulty you are facing, as he was telling? Why it is important? Can anybody come forward? Why communicating news is important? Yes, anybody? Please come forward, because this has to be interactive. Who raised the hand? Please come forward. Nobody? Suppose Dr. Shivasankar is telling me, madam, your lifespan is short. You may have another only 4 months. My heart condition is poor, so I may live for only 3 months or 4 months, because your ejection fraction is low, the left ventricular contractility is poor. Suppose he says like that. What I would think immediately? Actually, unless I know that, my expectations about my future will be very high. Is it not so? Any comments on that? Yes or no? My expectations about my future will be very high. I will be planning for a great future. Unless I know it, I cannot plan. So the most important thing that we want to know is about the lifespan. If we have an idea about the seriousness of my illness, I would like to plan so many things, because I have so many plans in my life regarding my children's education or somebody getting married or finishing a house which is under construction or settling some financial business. All these are belonging to closure of life's business. Don't you think it is important? Unless I know that my life is short, I cannot implement or I cannot plan anything or I cannot discuss anything with my family members. About the living will, already sir has said that also has value. It is very, very important. Unless I know that my disease is progressing, I may not think about it. My expectations are very high, but the realities are very poor. So unless I come to conciliation with the realities, I cannot make proper decisions. And also, some 30 years back, I have lost contact with somebody or I have a misunderstanding with somebody. I stop talking to them. That is the time to patch up relationships, to say thank you, to say sorry, I have pained you by my words. That is the ideal time to patch up relationships. So when you know your lifespan is short, you get time to patch up relationships, to say thank you, to say forgive me, to improve the enhance relationship. That is very important. And if I am in a hospital, I may not be getting better because I don't know the diagnosis, I don't know how the course of the disease is. So I may keep on nagging my family people that I'm not becoming better. So I can go to, please take me to another hospital. So actually, I don't know anything about my disease and course of the disease. So out of compulsion, they may take me to another place where the whole thing will be repeated with no benefit. In the end, what happens is I am migrating from one hospital to another, seeing one doctor to another doctor. That is a phenomenon called doctor shopping and hospital hopping. And that increases the mental stress, financial stress, and agony of both patient and the family members. And finally, what happens when every modality of comfort or treatment fails? What is usually done in the hospitals? They say nothing more can be done to please take him home. Is it not so? That is usually what is done in most of the places. So sir used to say, when somebody says that, we have so many things to do. So that is the time, never tell that sentence to anybody. It is like deserting them or abandoning them. So at that time what happens? I will be taken home. I will be pushed in a corner, end of life. So people from far and wide will come and see me and they will show sympathy, which I don't like. So I start hating everybody. Everybody is sympathizing with me. I don't know anything what is happening to me, but everybody is whispering around me. So I will be finding it difficult to cope with my family members. So that will result in strained family relationship also. So what happens in the end? I may die one day. At that time, big photograph will be put in the wall, garland will be put, and people in the family members will cry. And they will say, oh, if only we had more time to spend with her. There was time. No truth was told. No achievable hopes were discussed. No achievable expectations were discussed. So I will be having a miserable end. Anybody likes to make any comment on what we told so far? Anybody, anything you want to add on that? Yes? Anybody? Shall I ask? Yes. Very good.
Hello, good evening, ma'am. So, I'm Rajesh Kumar, final year student. So, I wanted to ask you a question. I can understand that we, in this profession, we are educated and we can understand this.
Rajesh, I have never exploited. That happens. But Rajesh, I usually find that the illiterate villager, maybe coming from the hilly areas beyond Palod, they are they find it much easier to accept a bad news. It is the well-educated people like you and I who find it hard. They are death literate. They know, they have no doubt that the death is the inevitable consequence of life. We are the ones who find it difficult. The only catch is we have to speak in their language. They'll ask plain questions. And they generally are much better at accepting bad future. Thank you.
Okay, let's move to Hariprasad. The biggest trauma in the life of a human being is death of his or her child when he or she is alive. I think sir would agree with me. And I've seen a lot of people who have never been able to overcome that trauma till the end of their life, however bold and brave and well connected and affluent they are. So pediatric palliative care, especially when there are situations where a lot of very rare diseases are coming, and in the community there have been a lot of moves where people are collecting money and importing medicines which are extremely expensive, which large number of people cannot do. There have been instances where some of the people have been able to save their kids' life like that. So what is it like end of life in a child? How to handle the emotions of the child, of the mother, the whole experience of pediatric palliative care. So,
Thank you. So at the outset, I sincerely thank Arun and the whole organizing team for inviting me for this program, and that too, along with my guru and mentor, Rajavan sir, from whom I learned the basics of palliative care. So, get on. Tell me, go. So I think pediatric palliative care is still in its infancy, and the main point is that we don't think that children will die. That's the most important point. But as in the past 25 years, we know that a lot of advanced medical treatment has come, and the infant mortality rate in Kerala is at percent 5. That means in a good number of children, the mortality is converted to morbidity. There's a complex heart disease, there's a healthy program, they go for a palliative surgery, the child survives. And we have got enzyme replacement program for various conditions. The children go on living, but the quality of life is compromised. Extreme preterm babies are surviving, 24 weeker, 25 weeker, but at least some babies develop complications and the life is crippled. So the mortality is replaced with morbidity, at least in Kerala. So the infant, the pediatric palliative care is an absolute need for the upper. So that's my first point. Regarding the dying process, no mother wants to see their child suffer. I can quote you many cases where the caregiver came to me and told me that, sir, please don't put him on ventilator. I am ready to sign that withdrawn from ventilator is possible, and I will sign that. So please sedate him so that he will not suffer. I know that he is not going to live along. So I think it is the pediatricians, which is the doctors who don't accept death of children. It is not that. So I think what we need is we have to empower, or we have to educate the pediatricians as well as the young doctors, so that they have to start practicing pediatric palliative care. And as everyone knows, we have to start practicing palliative care from the onset of diagnosis. And there was Rajavan sir was a member of the Lancet Commission, where it said that palliative care is needed for all serious health-related suffering. So there are a lot of children having serious health-related suffering, and we have to start pediatric palliative care from the onset of diagnosis itself. And if you have an empathetic conversation, if you take care of the child and the whole family in a systematic way, in an empathetic way, I'm sure that the mothers and all the caregivers will accept. There's no point that no caregiver, I don't think that any caregiver will not accept that. If they are not accepting that, actually, it may be a part of our mistake. I shall quote you one example. A few months back, we had a quadriplegic cerebral palsy child around 10 years old. And I was asked to talk with the mother. I had a series of discussion, and the mother asked me, സാറേ ഞാൻ 8 വർഷമായിട്ട് ഈ കുട്ടി ഇവിടെ കൊണ്ടുവരുന്നുണ്ട്, ഇതുവരെ ആരും എന്നോട് ഈ കുട്ടിക്ക് ശരിയാകത്തില്ലെന്നോ ഈ കുട്ടി ഇങ്ങനെയാണ് പ്രശ്നം വരുമെന്നോ അല്ലെങ്കിൽ അധികാരം പോകുമെന്നോ പറഞ്ഞിട്ടില്ല. ഞാൻ ആരെയും വിശ്വസിക്കും. 8 വർഷം ഞാൻ കണ്ട പല ഡോക്ടർമാരെ വിശ്വസിക്കണോ, ഞാൻ ഇന്നലെ കണ്ട സാറിനെ വിശ്വസിച്ചു. വാട്ട്സ് ആൻസർ? I think the answer is there. We have to start practicing palliative care wherever we are and whenever we are. And for pediatric palliative care, I think the best population to practice pediatric palliative care is a school senior pediatrician. Because even we can see volunteers who are afraid to touch children. The younger the baby, the more is the problem. And I think it is there even for senior doctors who practice adult palliative. They are afraid because some dose may go misspent, etc. And I think so. We have to, the only way out is to practice or to generalize or to sensitize pediatricians in pediatric palliative. I think.
So let's hear from the young blood regarding what is the concept of palliative care or even that. Because I remember during my convocation, we are supposed to bring out a magazine reflecting whatever we have done in the campus till then and probably our aspirations in the future. So there was this form which was circulated regarding what is your ambition for the future. Fortunately or unfortunately, I wrote it down that my ambition in life is to have a peaceful, painless death with a clear conscience. I never knew that during the convocation, this part would be read aloud. And after listening to this, after my convocation was over, one of my professors came to me and told me that you are the most greedy human being I've seen in my life, which I think is true because Rajagopal sir very clearly said that only 10% of the population get a chance to die that way. 90% suffer and die. So medical profession happens to be a profession where you need a lot of empathy, social intelligence and emotional intelligence. Unfortunately, we go through a very grueling competitive process which spreads hatred, animosity towards each other. Is that true? To a certain extent at least. So your thoughts about this topic, palliative care, that end of life care, we would like to hear.
Sir, very good evening to the respected members on the sides and to everyone present here. Death is absolute, right? Death is certain, at least in terms of what we have now in terms of medical advances. 100% of us are going to die. This is certain. But really, we come into contact with death on the first or the second day of our journey in MBBS. What I'm talking about is, of course, the anatomy dissection hall. That's when the concept of death really hits us. Because all of us are students of course, alumni of this college. I can speak about our dissection hall itself. 12 bodies, 12 or 13, just laying there, cold, waited to be dissected and analyzed and studied and reviewed and reviewed and reviewed by medical students. Really, the first few days, we think about them. We think about those bodies, what they went through, and what their journey was from life to in front of us. And that's our first contact with death as a medical student. And then we go into the clinics in second year and henceforth. And like Raj sir said, although it's a part of our curriculum since 2019, it's not taught to us. We have posting in physical medicine and rehabilitation where it's discussed, but even now, it's a very peripheral topic of discussion in the MBBS curriculum, at least as far as we are concerned until now. So the only contact we have with death is really accidental, for lack of a better word. Accidental in respect to us. The first time I and my batch encountered death was in fact in our posting in emergency medicine. For one day, we were posted in the EMICU. It was our first posting of second year. So we were posted in EMICU and we were asked by our unit chief to take the particulars from the case sheet of a patient who was on the ventilator. We noted his name, his age, why he was admitted, how he presented to the casualty, and all these things we noted. And we told this to our unit chief. And on the next day, when one of our batchmates said that there was one more particular that we should have noted, and we went to the EMICU again in search of this patient. The patient wasn't there. That bed was empty. So we went to the unit chief and we told this to him. His expression darkened and he told us the patient must have passed during the night. That one statement and that visual of that empty bed is what actually drove that point into our minds that death is going to be a constant in our medical life, no matter what field of medicine we choose. But now, hearing about this topic and thinking about this, I think about that patient, how he passed. He passed away in the EMICU, as Sir said, hooked up the cables, hooked up to machines, hooked up to all these things, not able to breathe on his own, not able to perform basic bodily functions on his own. His wife and his son were outside at the time we were entering. They weren't allowed to enter. And they were waiting for some test results and they looked anxious, they looked tired. And they weren't able to see this patient, their father, their husband, for hours and hours on end. Only visitations were allowed. It really drives the point home. Do I want to go like that? Do I want to pass on like that? Is this any humane way to go? So, really speaking, because our exposure to death is so sporadic in this career as a medical student, this episode really stuck with me. And this is my experience with death as such. And the lack of end-of-life care that we saw with patients who are in the ICU. Then, of course, you see patients in the wards in medicine and surgery. Several patients who have neurological problems. For just one example, hepatic encephalopathy, patients who have liver failure. They're tied up to the bed here. Of course, they have to be. For therapeutic reasons, they have to be. If we need to insert an IV line, they have to be. But again, when these patients go into that terminal stage, when they pass away in the middle of the night, they're going like this. They're going tied up to their beds. They're going, again, under the cold lights of our medicine wards. So, this really is my experience with death as a medical student.
Thank you, Siddharth, for those very enlightening, thought-provoking words. Please keep your questions ready to ask Sir, Ma'am, and Hariprasad Sir, and all the three panel members. So, one experience, Sir, I would like to share with you was that a person from a village near Trivandrum, a 75-year-old gentleman, presented to a general practitioner with low back pain, which was chronic and was not getting relieved with analgesics. The doctor did an investigation and understood that ESR was significantly high, more than 120. He had a doubt whether it was a multiple myeloma. Investigations were subsequently carried out, and the subsequent investigations showed the M-band and probable diagnosis. But he sent the patient out of his consulting room and revealed the bad news to the caretaker, the bystander, was his son, and told him that he should take him to the regional cancer center. The son thought that it was wise not to reveal the diagnosis to the father, and he was taken to the institute. He came to the portico in a car. He entered to the hospital without even revealing to father that it was the regional cancer center. Went and saw the doctor. The doctor sent for some more investigations. And he was asked to wait at a particular place. And unfortunately, exactly opposite that waiting place was a big board which had this literature. Things which cancer patients should take care of. Cancer rogigal does not take it. A few things. And that was probably that moment in which this elderly man realized that he was in a hospital which treats cancer. He collapsed there. So how effective is our art of revealing the truth or bad news or whatever it is? Especially because in theory we are taught about something called Spike's protocol in revealing bad news, which says S is setting. You have to opt for a place where it is a calm, serene environment where we can give undivided one-to-one attention to the patient or the caretaker. Then P is perception. We have to understand how much the patient or the bystander knows about their illness. Then we should ask them how much more they want to know, that is I, invitation. Then we should share knowledge, that is K, in non-jargon terms in an understandable fashion. Of course, the person is likely to break down or display emotions. We should allow him to vent out his emotions and empathize, that is E. And finally, we have got an S, that is to strategize and summarize. Even after the diagnosis has sunk into the mind of the patient, what are the lifestyle modifications which he should adopt so that the quality of his remaining life is going to be good? We teach theory to doctors, we talk about these things, but how effective is the communication in real life, sir, from your experience?
In a real life situation, ordinarily, there is no communication. And why? Possibly because we are scared. We don't know what to do. The prospects makes us afraid. The family member is safe. But friends, let me tell you, I don't know which one of you is going to treat me. Could be any one of you. This is my life. I have more right over this than anybody else, including my wife or my children. I have a right to know, and doctor, you have a duty to inform me. I know I am weak, I cannot go to court against you, I cannot fight for my rights, so my rights are ignored. Would you like to know what happens to you, Vilasini, if it was you? If there was a bad diagnosis, you would like to know. Ruma? How would you? Cruel question to ask to a young person. You want to know, or shall we tell your family? If he wants to know, I have a responsibility to tell him, but it should not be like breaking a bomb. When my time comes, friends, please sit down for just a minute. If possible, look into my eyes. Say what you see. I see you are very anxious. Would you like to tell me what's going through your mind? And even if you don't have time, even if you are the doctor in the primary health center who is to see 150 patients a day, still look at me, acknowledge me as a person. And if you then say, it appears to be just a viral fever, there is a problem, I'll see you in 3 days. And that makes me feel good. And if it's a bad news, find out what I know, find out what I want to know, and convey the information in small bits. Not everything together. After the first few words, I may shut off. I may not be in a frame of mind to know anything more. This is a process, if at all possible, to spend a few minutes on. If I need a tracheostomy, you will spend half an hour doing it. But here is something that will be life and business for me. Because I may be thinking, I want to know. Because if it is cancer, I want to kill myself today. That may be what's going through your mind, and you have to get to me as a person to understand that. So, fortunately for you, it's in the curriculum. If it is not being taught, it will be, hopefully, it should be. And communicating that news is both a science and an art. There is a science also. So, I hope you learn to do it. If you can spend time on Saturday afternoon, it's free for you. Go and see how Parvati is doing it to patients, or how Hari is doing it to the families of patients, or to grown-up children. And that will be truly rewarding, because you then will feel the warmth and the gratitude. You may have conveyed very bad news, but they may still say, "Thank you, doctor." Just one more point there, if I may make. Siddharth, no, I was asking, I don't permission. Siddharth, you said that this absolute, that used to be absolute. A few years back, you are either alive or you are dead. Now you are alive or brain dead, which is something like half dead, and then dead. So, unfortunately, that's getting complicated. So, this brain death is something that I know I don't really want to talk about. So, one of the problem is we knew what that was at one time. Our elders knew. The elderly neighbor would come and say, the lips are getting cold, better inform all the relatives. They knew, but now we don't know. Now we will have to keep them on a ventilator to see if organs can be transplanted. Very easy. And Dr. Hari Prasad earlier said, it has to be started at the time of diagnosis. That's not only for children. Doesn't mean that you refer the person to Dr. Parvati. It means that you apply the principles of palliative care into everything you do. It means that communication also.
The topic is open for your questions, your discussions, your sharing of experiences, and if any. It's a great opportunity to learn from the legends. Because again, as it has been told by Siddharth, it is there in the syllabus but not taught in the way it should be taught, probably.
May I add one thing? Sir was telling about. Can you hear me? Sir was telling about the end of life and communicating the news, everything, and knowing the person. I would like to add one sentence to that. All patients are persons with feelings that do matter. Do you agree with that? All patients are persons with feelings that do matter. So always respect the person behind it. He may be a Supreme Court justice, or he may be a part of the Harida Karma Sena, whoever it is. But there is a personhood. When a person becomes a patient, the patienthood eclipses on the person. He becomes bed number 36, or he becomes CA pancreas, or he becomes token 30, like that. Never think like that. You are budding doctors, that is why I am telling that sentence. Please, when you go to the ward, respect them as you are. How they want to respect you, in the same way you respect them. That is very, very important in our profession. Empathy cannot be taught. It is not given in book. What is empathy? There is no definition for empathy. It is an experience which you feel when you are in presence of another person. When I am in front of Sir, I feel he is full of empathy for me. So he will acknowledge my concerns. It is an experience which you feel, which other person make you feel. It cannot be taught in any other book. Please understand that empathy is an experience. You stand in the other person's shoes, think what will be their situation in this particular situation, what trouble they are undergoing through. All these you please think once. When you meet a patient in the ward, don't consider them as simply CA, MI, like that. Think them as persons and respect their feelings. When I remember my house agency days, when I used to ask the caregiver, never use the word bystander, they are all caregivers. So when I never used to ask the caregiver, did she have a good sleep in the night or did she take coffee in the morning? What I used to do was simply I examined the patient, checked the BP. I was an excellent house surgeon, I did everything properly. But now I understand or I remember how badly I have learned my profession. I regret that most of my professional life is wasted. Only 1% I did. Only the physical science I learned. I did everything that too, not talking to the patient. Shall I examine your abdomen? Shall I tie a BP cuff? Shall I do an IV puncture? Nothing I have asked. So they were all part of our job. Dear friends, I please repeatedly tell you, please have empathy in your mind. That is very, very important in your profession. Even if you know little, know how to acknowledge other person's concerns. Go stand in their chapels and think what they are undergoing. Thank you. Thank you for giving.
Okay, I'm inviting Shivashankar sir, former professor and head of Department of Cardiology, Sri Chitra Institute of Medical Science and Technology, one of our alumnus, to enlighten us about his thoughts about this topic.
It's very pleasant that this audience or this auditorium echoes the concern to the society many times, because in 1978 to 84 I was a medical student here, and 1984 the symposium on euthanasia was chaired by Professor V.C. Matthew Roy, and there were 4 student parents on side, this side 4 of us were, and I was very excited about the scientific advancements, and I was one person who spoke against euthanasia. But then, as sir and madam has really pointed out, the real life experiences make you really understand what it is important to have a end of life conversation with people. So I had my own father who had a little Parkinsonism and other issues, and in 82 years I took him to the hospital for a prostate surgery. He underwent surgery, everything was good. But then after that he told me only one thing: now don't take me to any hospital anymore. I'll be in my home with my whatever small things. I am very contented. And let me die there in peace. Whatever you want to do, you can do. But don't take me to anything single. So that was his personal experience after surgery. But then he wrote it as a will and kept it so that all my family, people as well as society was comfortable about it, whatever care I was giving to him. But then that type of contentment, how many of us can achieve is a difficult question, as I was telling. How will you receive your difficult diagnosis at that stage of life, and what are your ambitions? And what similarly, when I went for my corporate scholarship, I went to my dad and asked, and what shall I do? Should I go? You're not well. Then he said, I am not going to live a day longer since you are here, and not die a day earlier because you have left. So you do your work and your. So that is the contentment in the earlier generation had. The society could accept that, but now the society is little challenged. So myself and Dr. Santosh were house surgeons. The children used to come with diarrhea and die like flies. The only advanced ventilator we had was an APU bag. And the ICU care was a rarity because it was reserved for people who are hemodynamically unstable, who are younger, who are likely to survive. Ventilator was possibly available only in the theaters, I suppose. But from that stage, we have now improved because every hospital has got 65 ventilators, and that is where to ventilate or not to ventilate, you need an informed family doctor who knows the situations and background to guide us. It is true that science has been very, very fascinating because when I was a house surgeon, my cardiology professor diagnosed a child with endocardial fibrinolysis, told the parents that was only maybe 3 or 4 years of life. But after 20 years, I saw that girl as a budding doctor, MBBS student with only residual cognition. And I studied that cognition. That doctor is a practicing doctor in Pediatric. So this has happened in front, my miracles have happened in front of our eyes. So similarly, during my house surgery, I had a drug-induced thrombocytopenia, pancytopenia, given 2024 transfusions. That young boy died. But overnight, the granular cell colony stimulating factor was identified. It is a curable disease. So most of the disease, whether it is diabetes in early 20s with the discovery of it became a curable disease. 1948, Waxman disclosed streptomycin became a curable disease. And recently also, 4 year Dr. Vathra used to say, disease of bones, molds and stones, very painful conditions. The other day I was reading about the silencing RNA attached to the N-acetyl galactosamine given as an injection cures 4. So science is very rapid. The facilities are available at your doorsteps. Where to draw the line? It needs a lot of patience, compassion. The other day, yesterday, Manorama paper has the story of that 18-year-old girl, 15-year-old girl was transferred from SAT to Amrita, was on ECMO for the last 4 months, waiting for a lung transplant, spent about 88 lakhs, and she is no more resident. I was going through, was it really COVID or was it a viral infection, was what I was wondering. But the amount of effort that is spent is something which is phenomenal. Where to draw the line depending on the family and society. It's a difficult challenge, and that is where we have people like Dr. Rajagopal and Madam help us to talk to understand the empathy and the social aspects of the problem and see them through. I am so happy that this audience, this auditorium is again resonating the social commitment of each and every one of us. Thank you so much.
Yes, someone was asked. Yeah, yes, Rajesh.
Hello, sir. Hello, ma'am. First of all, I would like to say how I understood what is death. So, I don't know how many of you have spent hours in Samsan Ghat, but I do have spent, and I have seen the human body turning into ashes. So, how I see death is, death is a beautiful event. It's a beautiful starting of the next life. It's the end of sorrow. It's end of painful event which a person might be going through. So this is all in my mind. But I have 2 questions for respected sir and madam. First is how our life start is I did what my parents wish for. I went to the places where they asked me to go. I behaved the way the exact way they wanted me to. So my entire life is being a selfless. I didn't think about myself. So how are you expecting at the end of the life I will become very selfless to think about me? That is first question. Second question is being a very I'm talking about myself. Being a very emotional person. If my parents or my relative are on deathbed, I will still crave for 5 more years. So in that scenario, how will I accept the fact, or how should I know the art of letting go, which I can say? So how can I accept the reality, even though I know what is there, what is not? I know all the knowledge. So how should I prepare myself to accept the fact, and how should I learn the actual art of letting go in the life?
Rajesh, by the time you finished, I have already forgotten the first question. So I'll talk about that. So I'll leave that to Bhargavi. But about the second question, what I would do, Rajesh, is make you sit down here. When you say, I want my dad to live as long as possible, I would acknowledge that you are a very loving son. You do love your dad so much, don't you? I'm almost feeling jealous of you. And then I would get you to talk. You may tell me about how much your dad did for me, did for the whole family, how much you value him. I have to listen to that, I have to understand you. And then I may say, you and I both will work to keeping him as long as alive as possible, so long as he can be comfortable. But if you think you would like him to live longer, even at the cost of enormous suffering to him, maybe you should go and think about it a bit more. Would you like him to live a few minutes longer at the expense of a tube in the throat and all those suction going in and out causing him pain? Maybe that's a selfish thought. I would like you to think more about it. And then let's meet again after tomorrow. Something like that. I will give time to you for you to think. But I will acknowledge your suffering. First question, Parul.
Can you repeat the first question? As he said, I have lost track. You were a very obedient, truthful son. That I understood. So I never thought about myself. I agreed to everybody else, and so how can I be selfish at the end of my life? How can I be?
I agreed to what was my parents told. I was selfless as a son. How can you expect me to be selfless at the end of my life? That was the question. How can you expect me to be?
Accepting the way of how I want my death to happen is a very selfless thing.
Yeah.
So lifelong I have been a very selfless person. So at the end of life, I will be like a very selfish person to choose the way I want to live.
Okay.
Can I ask you one question back? You said you obeyed everybody. You were a very selfless person, looking after them. Whatever they said, you obeyed. So who is actually getting the pleasure from it? When your parents are happy by your behavior, what is the indirect pleasure behind it? Are you happy about it?
Actually, I am happy seeing them happy.
So you are also happy. So there is.
After seeing them happy.
You are also happy. So it is actually a two-way process. By making them happy, you are also becoming happy. Is it not so? So you cannot say you were selfless all through. Do you agree with that?
There are few instances in my life where I accepted the fact and maybe time will change. Then I accepted their decision and went on. So it is not like I'm every time happy with their decision. Sometimes I used to choose what they asked me.
Okay. Now, why you said how can I become selfish at the end of life? What made you ask that question?
This, as Arvind sir mentioned, the way a person wants a death, peaceful death, is a very selfish thing. So if I think how I want to die, won't it be a selfish of me? The way I want to die is particular way. I don't want to live.
Okay. What is your concept of good death?
Good death, for me.
It will vary from person to person. Do you agree with that? If I ask Ashwati, she may have a different answer. If I ask Rupa, she will have a different answer. It varies from person to person. So what is your concept of good death?
Good death. For me, I want a very conscious death. I should know I am going to die, and I will sit in the chair.
What is the physiological change during dying? Will you remember?
No, I don't want to get into science that particular.
Okay, continue.
So I just want, a conscious death. I should know this is my time, and I should pray God or whatever there is I should do, and I should choose my death. It's not like I'm dying because of some accident or something. I don't want that. I don't want to die out of heart attack or cardiac arrest or anything. I just want a nice death.
Have anyone the freedom to choose death? Who has the freedom to choose death?
That is what I'm saying. If you ask me a question, I will reply that this is how I want.
Has anybody has freedom to choose?
No.
Nobody has. So if I say when I want to die without any physical discomfort. Peaceful death, I should be free of any physical suffering. I should not groan, I should not cry, I should not have seizures, I should not be breathless, I need physical comfort. I need somebody to hold my hand or wipe my tear when I die. When I die, it is a very painful moment to leave the dear and near and leave the world. I would like to take farewell to them. I would like somebody. None of the physical comforts which I have made during my life is not going to help me. My house, my car, my material possessions, nothing is there. What is available at that time, which I can hope for, is the love or a helping hand, or sir sitting near me and holding my hand. I would prefer to die like that in my life. That is the best death I would like. Somebody acknowledging me in my life. That is the best thing I would like.
You just wanted to tell Rajesh. Rajesh is a hypothetical dying person. I will do my best to make your wish come true. But I'll also recognize that from time to time, what you wish may still change. You may be sitting in that chair and you may say, I want to lie down. And you may say, no, I'm feeling scared. I may find out why. Your feelings may change. And I'll have to recognize that. But my responsibility to make your wish come true as much as possible.
So, as as well, medical students as such, aside from our exposure to clinics by clinical internships or rotations, aside from that, we don't really have any experience in management, actual management. Aside from studying the management of conditions, we don't really have experience in actually doing it until we reach house urgency. So when I had to think about this end of life care, palliative care, and all these things, I had to think of it from a layman's perspective. What a regular bystander of a loved one would feel. So I decided to talk to my dad about this yesterday. And he was telling me about one of his great uncles who died recently. His grandfather's brother who died recently. 1 week, that man was in the hospital in the ICU. And actually, at the beginning of that week itself, the doctor had told his family that the chance of him walking out of the hospital in full health or even partial health was negligible. But even though expressly this man had told his family that he doesn't want to die in a hospital, he wants to die at home, and the son knew this and the wife knew this, when the decision time came to take that person off the ventilator, his relatives, the ones who were next to him, neighbors living close to him who had decided to accompany this wife and son to the hospital to see this man, they started asking, how can you speak like that? How can you even consider taking him off the ventilator? If he can live for 1 more week, shouldn't we do whatever we can? So I wanted to ask you, and of course, my dad wanted to point this out. The hospital is completely ready because that's 7 more days that person spends in the hospital, 7 more days where they have to pay all the necessary bills to the hospital. And all these are actual factors that we have to take into account when we're thinking of end of life care. So, sir, where really today is the problem? Is it the problem of the society in not able to accept that quality of death is also important and more important than prolonging life? Or is there a role that hospitals also play in not caring as much as they should about the quality of person dying?
Siddharth, that wife and daughter, the loving people, they find it difficult to take that decision. Very often they are asked to do it that instant. You are given a choice. What do you want? How long do you take to decide between aloo matar and gobi when you go to a restaurant and the waiter hands you a menu? There are 3 of you. You say, come back in 5 minutes. Because this important decision has to be taken. They need time. We acknowledge that you are suffering. You love your dad. You love your granddad. And that's understandable. Come, sit down. Let us talk about what you feel. And at some point, I'll point out that their love, if it is to be some kind of selfless love, will involve doing the best for him. I want you to sit down, talk between you, and decide what would be best for him and not for you. I may hopefully get him to look at it that way, and tomorrow they may most likely come and say, Doctor, it's okay. Let us stop this. Very likely, but they may not, and it may be too late to ask his opinion anyway.
Thank you, sir. So it was wonderful listening to all of you. It was an enriching experience. Thank you so much. Since we are into this discussion of passive euthanasia, because you highlighted that at the beginning, I'd like to ask this question to sir. At the moment, we have the Supreme Court guidelines, which says that there should be two boards, the primary medical board and the secondary medical board. And of course, we have the living wills at the same time. But if there is no living will, in cases where there are no living wills, is there any method actually where we can actually bypass? Do you have any suggestions, sir, at the hospital level itself? For example, we have these clinical ethical committees. And are these committees empowered to take decisions for critically ill patients or medically futile patients? Do you have any suggestions? Because right now we don't have any legislation. We just have guidelines. So in the event of a legislation coming up, certainly they will be approaching you for your valuable suggestions. Thank you so much.
Thank you. Yes, there is no law governing this in India. Until a law is passed, even if Kerala Assembly passes a law, it will apply at least to our state. It will be overriding Supreme Court verdict because this is law. But a couple of points to talk about it. First, one of the new things that was brought up in yesterday's Supreme Court judgment is to acknowledge that the term euthanasia is not valid in this context. They have given specific statement that hereafter only active euthanasia will be considered euthanasia. Instead of passive euthanasia, we will use the word withdrawing artificial life support. So this law was not about euthanasia. This Supreme Court judgment is not about euthanasia any longer. But still people use that word because over the last 8 years they have become used to it. The second point, sorry, you were asking about euthanasia. No, at the living will. Okay. And the boats. Unfortunately, the best way of avoiding all that is not to go to the hospital. Unfortunately, that's the way it is. The one negative thing that the Supreme Court judgments have done is to make things complicated. If you are in hospital, you have to get out of the hospital. If you are in the hospital, you have to go through the boards. Unfortunately, you cannot bypass that if you are in hospital. But the Karnataka government did something wise. So the primary board is easy. You always have a panel of 9 doctors within the hospital who understand this. And who are the 3 available form the primary medical board. It can be done within 1 hour. The secondary medical board has to have a doctor nominated by the district medical officer. That's where the delay comes. What the Karnataka government said was they already have a panel of more than 130 doctors who are empaneled for deciding on brain death for the purpose of organ transplantation. They just said, the health secretary passed an order saying that all the doctors who are empaneled for that purpose hereafter are deemed to be nominated by the DMO. That bureaucratic thing wouldn't have entered any of our minds, but he did that. So what happened was, this happened in St. John's Medical College. Primary medical board was already called, and the secondary medical board included a doctor from the neighboring another hospital. It cannot be from the same hospital. And he came and they could do this thing on the same day. So there are ways in which hospitals and governments can bypass it, or the legislative assembly can pass a law. In fact, we have given a request for that, but it's unlikely that this government will do it now.
I'm inviting S. Hanifa Rao, the Senior Citizen Service Council, on his words.
നമസ്കാരം. ഞാൻ മെഡിക്കൽ വിദ്യാർത്ഥിയല്ല, ഡോക്ടറല്ല. ഞാൻ മുതിർന്ന പൗരന്മാരുടെ ഒരു സംഘടനയെ പ്രതിനിധീകരിക്കുന്ന ആളാണ്. ഇവിടെ ഇങ്ങനെ ഒരു വിഷയം ചർച്ച ചെയ്യുന്നു എന്ന് എനിക്ക് പ്രിയപ്പെട്ട വിജയാനന്ദ സാറ് വിളിച്ചു പറഞ്ഞു. അപ്പോൾ ഇവിടെ വന്ന് ഇവിടുത്തെ ഈ സംഭാഷണങ്ങളൊക്കെ കേൾക്കാൻ ഞാനും എൻ്റെ സഹപ്രവർത്തകൻ ശ്രീ കൃഷ്ണകുട്ടിയും ഇവിടെ ചേർന്നിട്ടുണ്ട്. ഞങ്ങള് പിന്നെ ഒരു 20 വർഷമായിട്ട് ഈ ജീവിതാന്ത്യത്തെ കുറിച്ചുള്ള ഇത്തരം ചർച്ചകളിൽ പങ്കാളികളാവുകയും ജീവിതാന്ത്യത്തിലെ സഹനങ്ങൾ പരമാവധി കുറയ്ക്കുന്നതിന് നിയമപരമായും അല്ലാതെയുള്ള മാർഗങ്ങൾ ആരായുകയും ചെയ്യുന്ന ഒരു സംഘത്തിൽപ്പെട്ട ആളുകളാണ്. നമ്മള് ഇന്നലത്തെ സുപ്രീം കോടതി ജഡ്ജ്മെന്റിന്റെ ഒരു പശ്ചാത്തലത്തിൽ നിന്ന് കൂടുമ്പോൾ ഈ സെമിനാർ ഇന്ന് തന്നെ സംഘടിപ്പിക്കാനിടയായതിൽ അതിയായ സന്തോഷമുണ്ട്. അതിന് നേതൃത്വം കൊടുത്ത ഗവൺമെന്റ് മെഡിക്കൽ കോളേജിലെ പ്രത്യേകമായി അഭിനന്ദിക്കുകയും ചെയ്യും. ഞാൻ ഒരു കാര്യമാണ് പ്രത്യേകിച്ച് പറയാൻ വേണ്ടി ഇന്ന് ഈ മീറ്റിംഗിൽ നിൽക്കുന്നത്. അത് ലിവിംഗ് ബില്ലിനെ കുറിച്ചാണ്. ഈ ലിവിംഗ് ബിൽ എന്ന് പറയുന്നത് നമുക്ക് എല്ലാവരും പറഞ്ഞു. രാജഗോപാൽ സാറ് ഞങ്ങളുടെ നിരവധി മീറ്റിങ്ങുകളിൽ പങ്കെടുത്തിട്ടുണ്ട്. നമുക്കെല്ലാം അറിയാവുന്നതുപോലെ മരണം എത്തുന്ന നേരത്ത് നീ എന്റെ അരികിലിരിക്കുക നേരെ ഇരിക്കണം, എല്ലാ മനുഷ്യരും ആഗ്രഹിക്കുന്ന ഒരു കാര്യമാണ്. അതുപോലെ അന്തസ്സോടെയുള്ളതാണ്. ഈ ട്യൂബുകളൊന്നും എല്ലാ ശരീരമാസങ്ങൾ ട്യൂബും ഘടിപ്പിച്ച് ഒരു അന്യഗ്രഹത്തിൽ നിന്ന് വന്ന ഒരു മനുഷ്യനെ പോലെ അവസാന ഘട്ടത്തിൽ കിടക്കേണ്ടി വരുന്ന ഒരവസ്ഥ. ഇതിനൊക്കെ ഒരു അന്ത്യം ഉണ്ടായാലും അത് നിയമമുണ്ട്, സുപ്രീം കോടതി ജഡ്ജ്മെന്റ് ഉണ്ട്, പക്ഷേ ബോധവൽക്കരണം കുറവാണ്. ഇത് നടപ്പാക്കേണ്ട ഗവൺമെന്റുകൾക്ക് ഇച്ഛാശക്തിയും കുറവാണ്. അത് വേറെ പലവിധ റീസൺസ് അതിന്റെ പിന്നിൽ ഉണ്ടാവാം. അപ്പോൾ എനിക്കൊരു കാര്യം അഭ്യർത്ഥിക്കാനുള്ളത്, ഈ പാലിയേറ്റീവ് കെയർ, ലിവിംഗ് ബിൽ, എമ്പതി ഇതിനെ സംബന്ധിച്ചുള്ള ബോധവൽക്കരണ പ്രവർത്തനങ്ങളും അതുപോലെ എല്ലാ ഹോസ്പിറ്റലുകളിലും ഈ ലിവിംഗ് ബിൽ കൗണ്ടർ ആരംഭിക്കുകയും അവിടെ ബോധവൽക്കരണ പരിപാടി, അത് പ്രൈവറ്റ് ഹോസ്പിറ്റൽ ഉൾപ്പെടെ എല്ലായിടത്തും ഈ ലിവിംഗ് ബിൽ കൗണ്ടറുകൾ ആരംഭിക്കുവാനും ഒക്കെയുള്ള ഒരു മൂവ്മെന്റ് കൂടി നമുക്ക് ഈ മെഡിക്കൽ കോളേജിൽ നിന്ന് ആരംഭിക്കാൻ കഴിയണം. അതിനുവേണ്ടിയുള്ള ഒരു തുടക്കം കൂടി ഈ യോഗത്തിൽ ഉണ്ടാവട്ടെ എന്നാണ് എനിക്ക് അഭ്യർത്ഥിക്കാനുള്ളത്. സമയക്കൂടായതുകൊണ്ട് ഞാൻ കൂടുതൽ വിശദീകരിക്കുന്നില്ല. എല്ലാവർക്കും നന്ദി.
തീർച്ചയായിട്ടും വളരെ മഹത്തായ ഒരു സജഷനാണ്. ഡെഫിനറ്റ്ലി വിൽ ടേക്ക് ഇറ്റ്.
Good evening, sir. My name is Archana. I'm a psychologist working in the Cancer Center. For the past 14 years in oncology department I work here. 30 years at the counseling maintained on that. But I enjoyed doing counseling. But for the past 14 years in came to oncology, I rectified what is the difference between counseling and doing the functional counseling. കാരണം വെച്ച് കഴിഞ്ഞാൽ ഓങ്കോളജി സെന്ററിൽ വർക്ക് ചെയ്തപ്പോഴാണ് കൗൺസിലിങ്ങിനെ കുറിച്ചും ENC സ്റ്റാറ്റസിനെ കുറിച്ചും എനിക്ക് മനസ്സിലായത്. According to me, because I'm not from a medical background, only from science background, I thought that death is linked to ICU. Death will support in ICU in the person. But coming to oncology department, and I was working at ICC Pediatrics about 6 years. അപ്പോഴാണ് EHCയെ കുറിച്ചുള്ള ഒരു കുറച്ച് കൺസെപ്റ്റ് വരുന്നത്. എങ്ങനെയാണ് ഇത് പാരന്റ്സിനെ കൺവിൻസ് ചെയ്യിപ്പിക്കുന്നത്? But still I am in a struggle convincing parents. Like you said, I was struggling because ഇപ്പോഴും കൺവിൻസ് ചെയ്യാൻ പറ്റാത്തൊരു കാര്യം പീഡിയാട്രിക്സിലെ കുഞ്ഞിനോട് സംസാരിക്കാൻ പറ്റില്ല. I can entertain them, but പാരന്റ്സിനെ എൻഡ് ഓഫ് ലൈഫ് കെയർ വരുമ്പോൾ തന്നെ നമ്മൾ കൺവിൻസ് ചെയ്താലും നമുക്കത് പറ്റാത്ത കാര്യമാണ്. ആസ് ടോൾഡ് അത് തുടക്കമേ ഉണ്ടായാൽ നല്ലതായിരിക്കും. But people don't accept and professionals don't tell us. അതാണ് പീഡിയാട്രിക്സിനെ കേസ്. പിന്നെ എൻഡ് ഓഫ് ലൈഫ് കെയർ സാർ പറഞ്ഞു എനിക്കിപ്പോൾ കുറച്ചും എളുപ്പമാണ് അഡൽറ്റിനെ നോക്കാനായിട്ട്. ബിക്കോസ് ELC സ്റ്റാറ്റസ് ഡോക്ടേഴ്സ് ഓൾറെഡി ഡിക്ലെയർ ചെയ്ത് കഴിഞ്ഞാൽ കുറച്ചുകൂടി എളുപ്പമാണ് നമുക്ക് കൺവിൻസ് ചെയ്ത് ഒക്കെ പറയുന്നത്. ബിക്കോസ് വി ആർ ഗെറ്റിംഗ് ടൈം. നമുക്ക് അവസാന നിമിഷം വരെ കൊണ്ടുനടക്കേണ്ട ആവശ്യം വരുന്നില്ല. വി ആർ ഗെറ്റിംഗ് സ്പേസ്. അപ്പൊ കമ്മ്യൂണിക്കേഷൻ കൊടുക്കാൻ പറ്റുന്നുണ്ട്, അവരെ കൺവിൻസ് ചെയ്യാൻ പറ്റുന്നുണ്ട്. അതുകൊണ്ട് സാർ പറഞ്ഞ ഫുഡ് വയർസും കേബിൾസും ഒന്നും ഇല്ലാതെ ESC സ്റ്റാറ്റസ് വളരെ ഭംഗിയായിട്ട് തന്നെയാണ് നമ്മൾ കൺവിൻസ് ചെയ്തത്. സാറ്റിസ്ഫൈഡ് ആയിട്ടാണ് അവരുടെ എല്ലാവരുടെയും കൺവിൻസിങ്ങോടെയാണ് പോകുന്നത്. സോ ദാറ്റ്സ് ഓൾസോ ഫൈൻ. മാഡത്തിന്റെ കേസ് പറഞ്ഞില്ല, മാഡം ഞാൻ ലിസൺ ചെയ്യുമായിരുന്നു. പേഷ്യൻസിനോട് പറയാനുള്ള അനുമതി മിക്കവാറും ഞങ്ങളുടെ ബാരിയർ സെക്യൂരിറ്റി കെയർടേക്കേഴ്സ് ആണ്. പേഷ്യൻസിന് വേണമെന്ന് പറഞ്ഞാൽ പോലും ചിലപ്പോൾ അൺകോൺഷ്യസ് ആണെങ്കിൽ പോലും എപ്പോഴും കെയർ ടേക്കേഴ്സ് ഞങ്ങളോട് അനുമതി തരാറില്ല. ഞാൻ അറിഞ്ഞാൽ മതി, ഈ മരിക്കാൻ പോകുന്ന അച്ഛൻ അത് അറിയേണ്ട ആവശ്യമില്ല, അല്ലെങ്കിൽ അമ്മ അത് അറിയേണ്ട ആവശ്യമില്ല. ഇത്രയും നാളും അവർ സന്തോഷത്തോടെ ജീവിച്ചാൽ അതങ്ങനെ ഓക്കെ. സോ സം ടൈംസ് വി ആർ ഹോൾഡ് ഓൺ, വി ആർ ഹോൾഡ് ബാക്ക്. അത് പറയാൻ പറ്റാത്തൊരവസ്ഥയിലാണ് ഞങ്ങൾ പോകുന്നത്. ഞാൻ ഫേസ് ചെയ്യുന്ന റിയാലിറ്റിയിലാണ് പറഞ്ഞത്. എവറിത്തിങ് എനിക്ക് അക്സെപ്റ്റ് ചെയ്യാൻ പറ്റും, എനിക്ക് മനസ്സിലാക്കി കൊടുക്കാൻ പറ്റും, എല്ലാം കൺവിൻസ് ചെയ്യാൻ പറ്റും. But facing the reality, ചിലപ്പോൾ numbers ആണ്, especially pediatric parents and some caregivers.
ഓക്കെ, എനിക്ക് മാഡം ആ ചോദ്യം ചോദിച്ച് വളരെ നല്ലൊരു കാര്യമായിട്ട് വിചാരിക്കുന്നത്. അപ്പോൾ ഞാൻ 2 എക്സാമ്പിൾ വെച്ച് തുടങ്ങാം. ഒന്ന്, ഞാൻ എറണാകുളം മെഡിക്കൽ വർക്ക് ചെയ്യുമ്പോഴാണ് കുട്ടിക്ക് ലുക്കീമിയ ഡയഗ്നോസ് ചെയ്തു. എയിംസ് ഭുവനേശ്വറിൽ ട്രീറ്റ് ചെയ്തു. 3 വർഷം കഴിഞ്ഞു. കുട്ടി ആദ്യം ക്യൂറായി, പിന്നെ ലാബ്സ് അടിച്ചപ്പോൾ അവർ പറഞ്ഞു, എയിംസ് ടീം തന്നെ പറഞ്ഞു, ഇത് ഇനി ശരിയാകത്തില്ല, കുട്ടിക്ക് സപ്പോർട്ട് കെയർ മാത്രം മതി. നമുക്കറിയാം, നമുക്കൊരു 30-35 ലക്ഷം ആൾക്കാർ, നോർത്ത് ഈസ്റ്റ് ആൾക്കാർ ഇവിടെ ഉണ്ട്. അപ്പോൾ ഇവിടെ ബന്ധുക്കളെ ഇവിടെ വിളിച്ചു. അവർ ഇവിടെ കേരളത്തിൽ വന്ന ആദ്യം എല്ലാത്തിനും ചികിത്സയുണ്ട്, ഇവിടെ പോയി നമുക്ക് ഒറ്റമൂലി കിട്ടും, ഇവിടെ വന്നാൽ ക്യാൻസർ മാറും. 2 ദിവസം കഴിഞ്ഞ് അവർ എറണാകുളത്ത് ലാൻഡ് ചെയ്തു. ഒറ്റമൂലിയൊക്കെ കഴിച്ച് ഒരു 1-2 ആഴ്ച കഴിഞ്ഞപ്പോഴത്തേക്ക് സിവിയർ പെയിൻ, 10 out of ഭയങ്കര പെയിനും വേദനയും മാസീവ് ബ്ലീഡിംഗ് ആയിട്ട് നമ്മുടെ എറണാകുളം മെഡിക്കൽ കാഷ്വാലിറ്റി വന്നു. അഡ്മിറ്റ് ചെയ്തു. എൻ്റെ യൂണിറ്റിൽ തന്നെ ആയിരുന്നു. അപ്പോൾ സംസാരിച്ചപ്പോഴത്തേക്ക് നല്ലൊരു അഡോളസൻ കുട്ടി, 12 വയസ്സുള്ള പെൺകുട്ടി. അപ്പം സംസാരിച്ചപ്പോഴത്തേക്ക് ആക്ച്വലി അവർ കേം വിത്ത് എ ഫോൾസ്ഹുഡ്. കാരണം അവരോട് ഡോക്ടർ എയിംസ് ടീമാണ് പറഞ്ഞത് ശരിയാകത്തില്ല, പക്ഷേ എങ്കിലും ഇവിടെ വന്നാൽ ശരിയാവുന്ന പ്രതീക്ഷയാണ് പറഞ്ഞത്. അപ്പം ആക്ച്വലി ആ കുട്ടിക്ക് നമ്മളെ ഹിന്ദി അറിയാത്തവരാണ്. അപ്പം we had a very in-depth discussion with the child separately, with the mother, with the father, and all the caregivers. അപ്പം അവർ അവസാനം കുട്ടി ഞങ്ങളോട് പറഞ്ഞത്, സാർ എനിക്കറിയാം ഞാൻ മരിക്കണം, അതിനു എനിക്ക് എൻ്റെ വീട്ടിൽ പോയി മരിച്ചാൽ മതി. അപ്പോൾ ആദ്യം ഈ കുട്ടിക്ക് ഇതറിയാമെന്ന് പേരൻസ് അറിയുന്നില്ല, കാര്യം ആ ഒരു കമ്മ്യൂണിക്കേഷൻ വന്നിട്ട്. അപ്പോൾ അവർ തമ്മിൽ അഭിനയിച്ചുകൊണ്ടിരിക്കുകയാണ്. അഡോളസൻ കുട്ടിയാണ്. അപ്പം കുട്ടി അമ്മയുടെ മുമ്പ് അഭിനയിക്കുകയാണ്, അമ്മ കുട്ടിയുടെ മുമ്പ് അഭിനയിക്കുകയാണ്. അപ്പം ആക്ച്വലി വി ഹാഡ് എ ലോട്ട് ഓഫ് ഡിസ്കഷൻ. അവസാനം വി ഹാഡ് എ കമ്പൈൻഡ് മീറ്റിംഗ്. അവസാനം അവർ തീരുമാനിച്ചു. അപ്പം കുട്ടി മരിക്കുമെന്ന് കുട്ടിക്ക് അറിയാമെന്ന് അമ്മയ്ക്ക് മനസ്സിലായി, കുട്ടി മരിക്കുമെന്ന് അമ്മയ്ക്കും അറിയാമെന്ന് അമ്മയ്ക്കും മനസ്സിലായി. അപ്പം അവസാനം നമ്മൾ അവന് പെയിൻ മാറി, ബ്ലീഡിങ്ങിന് സപ്പോർട്ടീവ് മെഷേഴ്സ് ഒക്കെ കൊടുത്തു. ആ കുട്ടി പറഞ്ഞതുപോലെ കുട്ടി നമ്മൾ തിരിച്ച് ട്രാൻസ്പോർട്ട് ചെയ്തു. വിഹാടെ ഒരു വളരെ ഹെർക്കുലിയൻ ടാസ്ക് ആയിരുന്നു. എങ്ങനെ പോകും, കാര്യം പോകുന്ന വഴി ചിലപ്പോൾ ബ്ലീഡിങ് വരാം. അവസാനം കുട്ടി ട്രാൻസ്ഫർ ടു ഭുവനേശ്വർ എയിംസിലേക്ക്. അവിടുന്ന് വീട്ടിൽ പോയി. അവിടുന്ന് കുട്ടി വീട്ടിൽ കിടന്ന് മരിച്ചു. അവിടെ കിടന്ന് 10 മിനിറ്റ് കുട്ടി അമ്മ എന്നെ വിളിച്ചു, സാർ വളരെ നന്ദി, കുട്ടി അവളുടെ ആഗ്രഹം പോലെ തന്നെ വീട്ടിൽ കിടന്ന് മരിച്ചു. അപ്പോൾ ഐ തിങ്ക് നമുക്ക് ഇഫ് യു സ്റ്റാർട്ട് ദി ഇംപ്ലിമെന്റിംഗ് ദി പ്രിൻസിപ്പിൾസ് ഓഫ് പാലിയേറ്റീവ് കെയർ as soon as you come in touch with the child. നേരത്തെ പറഞ്ഞതുപോലെ ideally we should start practicing palliative care at the onset of diagnosis, especially man-illness വേണം. എല്ലാ on chronic diseases we have to start supporting palliative care along with curative therapy. പക്ഷെ അതുകൊണ്ട് നടക്കുന്നില്ല. എങ്കിൽ നമ്മുടെ ഇൻസ്റ്റൻസ് നമ്മളോട് ഫസ്റ്റ് കോൺടാക്ട് തന്നെ വരുമ്പോഴത്തേക്ക് പ്രിൻസിപ്പിൾസ് ഓഫ് പാലിയേറ്റീവ് കെയർ നടന്നാലും ഇംപ്ലിമെന്റ് ചെയ്താലേ നമുക്കറിയാൻ പറ്റും. ആൻഡ് സാർ നേരത്തെ പറഞ്ഞതല്ലേ, എമ്പതറ്റിക് കമ്മ്യൂണിക്കേഷൻ ആൻഡ് ബി ട്രൂ ടു ദം. Never tell them lie. അങ്ങനെയാണെങ്കിൽ തീർച്ചയായും they will accept that. And no parents want to see their child suffer. രണ്ടാമത്തെ കാര്യം, ഇവിടെ RCS എന്നുള്ള കുട്ടിയാണ്, ഒരു മെഡിക്കൽ ക്ലാസ് തൃശ്ശൂർ എന്നുള്ള കുട്ടിയാണ്. ആ കുട്ടി ഇത് കുറച്ച് വർഷങ്ങൾ മുമ്പാണ് ഇതുപോലെ തന്നെ 2 വർഷം ട്രീറ്റ് ചെയ്തു, ലാപ്സ് വന്നു. ആക്ച്വലി അവർ 2 വർഷം പുറത്ത് താമസിക്കുകയായിരുന്നു. ആൻഡ് ആ കുട്ടിയുടെ പ്രശ്നം വെച്ചാൽ സാധാരണ അച്ഛന്മാരാണ് ഈ ഫാമിലി കണ്ടത്. ഇവിടെ കുട്ടിയുടെ അമ്മ കുട്ടിയെ വിട്ടിട്ട് പോയി. അപ്പോൾ കുട്ടിയെ നോക്കിക്കൊണ്ടിരുന്നത് കുട്ടിയുടെ അച്ഛനും അമ്മയുടെ അമ്മയും കൂടാണ്. 2.5 വർഷമായിട്ട് അവരിവിടെ താമസിക്കുകയായിരുന്നു. ലാംസ് വന്നു, മെന്റൽ മിഡ്സ് വന്നു. അപ്പം അവർ RCC പറഞ്ഞു, ഇവിടെ നമുക്ക് IP ഫെസിലിറ്റിയിൽ നിങ്ങൾ വീട്ടിൽ പോയാൽ മതി. സിവിയർ പെയിൻ ആണ്ട് ഫെസിലിറ്റി വന്ന് അഡ്മിറ്റായി. ഇതുപോലെ തന്നെ അപ്പം വി ഹാഡ് എ ലോട്ട് ഓഫ് ഡിസ്കഷൻ. കുട്ടി പറഞ്ഞു, സാറേ എനിക്ക് വീട്ടിൽ പോയാൽ അവർ പേടിച്ച് ഐസ്ക്രീം പോലും കൊടുക്കുന്നത്. കാര്യം ഐസ്ക്രീമാണ് ഇൻഫെക്ഷൻ വരുന്നത്. അപ്പോൾ ആ കുട്ടിയുടെ സംശയം അവൻ പറഞ്ഞു, സാറേ എനിക്കറിയാം ഞാൻ വയ്ക്കും. അപ്പം കുട്ടി ആഗ്രഹം പറഞ്ഞു, എനിക്ക് മുട്ടായി വേണം, എനിക്ക് ഐസ്ക്രീം വേണം, എനിക്ക് ആഹാരം വേണം, എല്ലാം വാങ്ങിച്ചു കൊടുത്തു. വി ട്രാൻസ്പോർട്ടർ ബേബി ബാക്ക് ടു തൃശ്ശൂർ. ആ കുട്ടി തൃശ്ശൂർ മെഡിക്കൽ കോളേജ് അഡ്മിറ്റായി. അവിടെ നിന്ന് സ്റ്റെബിലൈസ് ചെയ്ത് ആ കുട്ടി വീട്ടിൽ പോയി മരിച്ചു. അപ്പോൾ എനിക്ക് തോന്നുന്നു, ഐ തിങ്ക് ഇഫ് യു സ്റ്റാർട്ട് പ്രാക്ടീസിങ് പാലിയേറ്റീവ് കെയർ, തീർച്ചയായും നമുക്കത് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യാൻ പറ്റും, അത് നടപ്പാക്കാനും പറ്റും, ഇൻക്ലൂഡിങ് എൻഡ് ഓഫ് ലൈഫ്. ഒരു എക്സാമ്പിൾ പറയാം. ഒരു 2 മാസമുള്ള കുട്ടി ബൈലാറ്ററൽ ഡിസ്പ്ലാസിക് കിഡ്നിയാണ്. നമുക്കറിയാം ബൈലാറ്ററൽ ഡിസ്പ്ലാസിക് കിഡ്നി റീനൽ ട്രാൻസ്പ്ലാന്റ് മാത്രമേ പറ്റത്തുള്ളൂ. ബട്ട് ഒരു മിനിമം ഒരു 10 കിലോ ഇല്ലാതെ കുട്ടിയെ ട്രാൻസ്പ്ലാന്റ് ചെയ്യാൻ പറ്റും. അപ്പം ദൈവർ ടെക്കി ഫെലോസ്. അപ്പോൾ അവർ ഗൂഗിൾ ചെയ്തപ്പോൾ അവർ കണ്ടു, ഡയാലിസിസ് ചെയ്താൽ ഇങ്ങനെ ലൈഫ് പ്രൊളോങ് ചെയ്യാൻ പറ്റും, എങ്ങനെയെങ്കിലും കുട്ടിക്ക് 10 കിലോ ആക്കാൻ പറ്റും. ആൻഡ് മദർ വാസ് വില്ലിംഗ് ടു ഡൊണേറ്റ് ഹെർ കിഡ്നി. അപ്പോൾ അവരിങ്ങനെ ആക്ച്വലി ബേബി വാസ് പുട്ട് ഓൺ ഡയാലിസിസ്. അറിയാമല്ലോ, കുറേ ഡയാലിസിസ് ചെയ്യുമ്പോൾ വെയിനെല്ലാം പോയി, കട്ട് ഡൗൺ ചെയ്തു, അത് പോയി, ലൈനായിട്ട് അത് ഇൻഫെക്ഷൻ അടിച്ചു. ഫൈനലി ബൈലാറ്ററൽ ഫെമറൽ കട്ട്, ബൈലാറ്ററൽ വീനസ് കട്ട് ഡൗൺ ചെയ്തു. അപ്പോൾ എല്ലാം കട്ട് ഡൗണും എല്ലാ വെയിൻസും എല്ലാം കൊളാപ്സ് ചെയ്ത് മാസീവ് ഇൻഫെക്ഷൻ, ഡൈഡ് ഓഫ് സെപ്സിസ് ഇൻ ദ PIC. അത് കഴിഞ്ഞിട്ട് മദർ, both the parents, the mother when it was severe. കാര്യം എന്താണ്, the guilt of giving എന്താണ് agony to the child till the last. അതുകൊണ്ട് that took nearly 3 years for the parents to come back out of depression. And അവരുടെ ഒരു എന്താണ് ഫോഴ്സ് ഹോപ്പ് കൊണ്ടാണ് they went for dialysis. എങ്ങനെയെങ്കിലും കുട്ടിയെ രക്ഷിക്കാൻ വിചാരത്തിലാണ്. പക്ഷേ പിന്നെ അവർക്ക് മനസ്സിലായി, എന്തായാലും ശരിയാകത്തില്ലായിരുന്നു, ഞാൻ എന്തിന് എൻ്റെ കുട്ടിയെ ഡയാലിസിസ് സംബന്ധിച്ചു, എന്തിന് എൻ്റെ കുട്ടി ഇത്രയും ബുദ്ധിമുട്ടി. സോ ദാറ്റ്സ് അനദർ ആസ്പെക്ട് ഓഫ് ദ പോയിന്റ്. ഞാൻ പറഞ്ഞത്, ഐ തിങ്ക് as a person, if you start practicing palliative care at the onset of contact with the person and with the family, and our good, if you continue the journey along with them, they will trust you and be true to them. They will trust you, and definitely I think we will be able to implement pediatric palliative care, including end of life in all children. There's no doubt, and continue to support them as long as they are rehabilitated into the family, into the society, back to normal. Adum വേണം. That's the grief and bereavement support. അതെനിക്ക് ഡെഫിനറ്റ്ലി നമ്മുടെ സാറാണ് ധാരാളം ചെയ്യുന്നത്. 15 മിനിറ്റ് നമ്മുടെ കുട്ടികളെല്ലാം bereavement support കൊടുക്കുന്നത് 15 മിനിറ്റ്.
So before I forget, can I ask a couple of questions? One was about the question of brain death and organ donation. It's very closely related to this. So certification of brain death and donating organ donation has become a spiritual or philosophical process in which a life is enlightening or enriching so many other lives. It has been celebrated in media like that, it has been picturized, portrayed like that. So about this process of brain death certification and organ donation is one thing. And second thing is, again, I know it's not a scientific question to ask here. I would like to get the personal opinion of the 3 panelists on this question. It's a very spiritual question. I guess you have guessed the question already. What happens to a person after his death? So these 2 questions. After his death, is there something called soul? Is there rebirth? Your personal thoughts about that.
About organ transplantation. Once the person is diagnosed as brain death by that panel of experts, the person is deemed dead and is continued on artificial life support only for facilitating organ transplantation, and once the organs are harvested, the process is stopped. I suppose there is a sort of spiritual healing for the family that my whole child has not died. He or she still lives in somebody. I suppose so. I do not know people people well enough about that. But the context that we have been talking was definitely not about brain dead people. Let's have it very clear. So far, this last 1 hour and a half, we were not talking about brain dead people. It was maybe about vegetative people who may have some brain function, but still has enough brain function to suffer. That's the usual unfortunate situation. So that's all we were talking about. In the case of brain death being diagnosed, the person is considered dead. The second question was philosophical. My usual policy is all difficult questions in Parliament are handled by Parvati. What happens to the soul if there is such a thing once a person is gone?
What I would like to share is one story I heard about Ramana Maharshi. I heard that he had sarcoma and he refused treatment because he was suffering, body was suffering, plus mind was suffering. Because he was a Maharshi, probably mental suffering must have been less, I don't know. But when he was compelled for treatment, what he said was, my body has become useless physically. So don't try to treat that physical body. My soul has plenty of good bodies to go. So why do you want to treat this physical body? That is the question he asked, and he refused treatment. And personally, I do believe that there is a soul that will be, because I believe that genes are passing on from one generation to another. So that will be related to our soul. That is my personal belief. I'm not an authority on that. So definitely soul exists. That is what I believe. So that is my thought. So the body only dies. In Hindu philosophy, they say about Panchabhutas. What has come from Panchabhutas will go back to Panchabhutas. That is why they burn the body in the end. So other thought remains. That is my personal belief, because I believe. Thank you.
Let me just add one sentence. Parvati, in answer to his question, if I am treating you, I will respect what you believe. I will go by what I do. And when you treat me, don't try to, of course you will not, force your beliefs on me. I don't know what happens there. I have written in my advanced medical directive that my body should go to, and it's not here, Department of Anatomy and Trivandrum Medical College. I don't know. I'm happy to meet with whoever is there at that time, or if there is nothing, that also is fine with me. The point is, you don't try to inflict your beliefs on anybody. You get to know the person enough so that you understand their beliefs, respect that, and don't try to change them. You go with that. Sorry, Eddie.
എൻ്റെ വിശ്വാസം there is life after death എന്നാണ്. കാരണം ഞാനിങ്ങനെ കുറെ ക്വസ്റ്റ്യൻ ചോദിച്ചു കുറേ നോക്കി, അപ്പോഴത്തേക്ക് ആദ്യം സ്ട്രൈക്ക് ചെയ്തത് ജീസസ് ക്രൈസ്റ്റിൻ്റെ ആണ്. അത് ആറായിട്ട് വെച്ചാൽ റെസ്റ്റ് ഇൻ പീസ് അല്ല, ഇറ്റ് ഈസ് റൈസ് ഈസ് പോസിബിൾ എന്നാണ്. പിന്നെ ഞാൻ ഓട്ടോബയോഗ്രഫിക്കൽ യോഗി വായിച്ചു. അപ്പം അതിനകത്ത് ഹി ഡിസ്ക്രൈബ്സ് 3 forms of life: ഫിസിക്കൽ ലൈഫ്, ഓർ സെൽഫ് ലൈഫ്, ഓർ സെൽഫ് ഫോം ഓഫ് ലൈഫ് എന്നൊക്കെ പറഞ്ഞിട്ട്. അപ്പം അങ്ങനെ കുറെ ക്വസ്റ്റ്യൻ ചോദിച്ചപ്പോഴത്തേക്ക് പിന്നെ ഐൻസ്റ്റീൻ്റെ ഒരു തിയറി ഉണ്ട്, എനർജി ഇസ് നൈദർ ഡിസ്ട്രോയ്ഡ് നോർ ക്രിയേറ്റഡ്. വി ഹാവ് എൻ എനർജി. അപ്പം നമ്മളിൽ നിന്നും എനർജി പോകുമ്പോൾ നമ്മൾ ഡെത്തായി. ആ എനർജി എവിടെ പോകുന്നു? ഇറ്റ് ഈസ് നോട്ട് നൈദർ ക്രിയേറ്റഡ് നോർ ഡിസ്ട്രോയ്ഡ്. സോ ദാറ്റ് എനർജി ഇസ് സംവെയർ. So that energy has to come. So I strongly believe that there is life after death, and I will come back after my death. I don't know in which form. Thank you.
Thank you very much for that.
That is true, Hari. I do believe that. Okay. But as he said, we should not force our beliefs on others. I agree with you.
Yes, ma'am, please.
ഞാൻ സാധാരണ ഒരു അമ്മയാണ്. എല്ലാവരെയും ഇഷ്ടമാണ്. വിശുദ്ധ ബൈബിൾ
ഞാനൊരു സാധാരണ അമ്മ. വിശുദ്ധ ബൈബിളിലെ ഒരു വചനം ഉദ്ധരിക്കുവാൻ ഞാൻ ആഗ്രഹിക്കുന്നു. മാത്യു 5:12. മറ്റുള്ളവർ നിനക്ക് എന്ത് ചെയ്തു തരണമെന്ന് നീ ആഗ്രഹിക്കുന്നത് അതാദ്യം നീ അവർക്ക് ചെയ്തു കൊടുക്കണം. ഗിവ് ആൻഡ് ടേക്ക്. ആ പോളിസിയാണ് എനിക്കിഷ്ടം. മറ്റുള്ളവരെ നമ്മളെക്കാട്ടിൽ മേന്മയുള്ളവരായി കാണുക. എവിടെ ചെന്നാലും പരാനുഭൂതി അത് എവിടെ ചെന്നാലും എല്ലാവരോടും വേണം. ഞാൻ ആശ്രയയിലും കെയർ പ്ലസിലും വർഷങ്ങളായിട്ട് പോകുന്നതാണ്. രോഗികളെ വിസിറ്റ് ചെയ്യാൻ പോകും. അവരോടെല്ലാം ഒത്തിരി സീരിയസ് ആണെങ്കിലും അവരുടെ അടുത്തിരുന്ന് ഒരമ്മയുടെ സ്നേഹം പകർന്നു കൊടുക്കും. എത്ര സീരിയസ് ആയിട്ടുള്ള രോഗികളാണെങ്കിലും അവരെ പറഞ്ഞൊക്കെ ചിരിപ്പിച്ച് ഒരു പോസിറ്റീവായിട്ടുള്ള എനർജി അവർക്ക് പകർന്നു കൊടുക്കുവാൻ എനിക്ക് സാധിച്ചിട്ടുണ്ട്. അതിൽ നിന്ന് അവരനുഭവിക്കുന്ന സന്തോഷം ഞാൻ എല്ലാവരോടും ചോദിക്കാറുണ്ട്, നിങ്ങൾ ദൈവം ചിരിക്കുന്നത് കണ്ടിട്ടുണ്ടോ എന്ന്. ഇപ്പൊ ആളുകൾ പറയില്ല, കണ്ടിട്ടില്ല. എന്നാൽ ഈ ബ്രസ്റ്റൊക്കെ പുഴുത്തിട്ട് ഇതിനകത്ത് മെഡിസിനൽ ടർപ്പന്റെ ഒഴിച്ചു കൊടുക്കുമ്പോൾ പുഴുക്കള് ചാടും. വെള്ളപ്പുഴുക്കൾ ചാടുമ്പോൾ അത് പെറുക്കിയെടുത്ത് കഴിയുമ്പോൾ അവർക്ക് ആ വേദന കുറയുമ്പോൾ അവർ ചിരിക്കും. ആ ചിരിയാണ് ദൈവത്തിന്റെ ചിരിയെന്ന് വിശ്വസിക്കുന്ന ഒരു അമ്മയാണ് ഞാൻ. ഒറ്റ ഒരു കാര്യം ഓർക്കുക, ഒരു വചനവും കൂടെ ഉദ്ധരിക്കുകയാണ്. നീ നിന്റെ ജ്ഞാനത്തിൽ പ്രശംസിക്കരുത്, ബലവാനെ നീ നിന്റെ ബലത്തിൽ പ്രശംസിക്കരുത്, ധനവാനെ നീ നിന്റെ ധനത്തിൽ വലിപ്പം ഭാവിക്കരുത്. നീ പ്രശംസിക്കുന്നുവെങ്കിൽ നല്ലവനായ ദൈവം നിന്നെ സ്നേഹിക്കുന്നു, നിന്നെ കരുതുന്നു എന്ന് അറിയുന്നതിൽ നീ പ്രശംസിക്കുക. ഒറ്റ കാര്യം ചെയ്താൽ മതി, ഉള്ളു തുറന്ന് മറ്റുള്ളവരെ സ്നേഹിക്കുക. ഞാനെന്ന ഭാവം വെടിയുക. നമുക്ക് അത്ഭുതങ്ങൾ പ്രവർത്തിക്കാൻ സാധിക്കും. Thank you very much. Thank you. God bless you.
Thank you very much, ma'am. And since we have a few psychiatrists also here, we would like to get the opinion of some. There is Dr. Pranav, who is the most favorite teacher of students. There is Dr. Jerry here, who was the moderator of the previous panel discussion, and there is Dr. Dinesh RS, consultant psychiatrist, MHC. So I think the youngest of the lot happens to be Jerry. I would like to hear from Jerry regarding the emotional aspects of end of life care, because the title of our topic for today is On Death and Dying. It's a very celebrated book written by Elizabeth Kubler-Ross. And when a person is diagnosed with a very deadly disease or a disease which is significant, there are 5 stages through which a person's emotional state goes through, which every doctor is supposed to know, understand, and put into practice. So we'll listen to Jerry's words.
Thank you, Arun sir. I thank the panel and sir for inviting me again to this platform. Good evening to the esteemed panel, and first of all, thank you to the organizers for this topic. A topic of this magnitude that has not been discussed before is absolutely essential in the medical spectrum. So huge thank you to the organizers for that. And coming to the point that sir has stated, the emotional aspects of end of life care. To be very honest with you, me as a student at medical school and even in psychiatry, our exposure to death and how to deal with death is not substantial, if I may put it very honestly. So along the emotional aspects, as a doctor, my question to the panel would be, if I am a doctor who has to deal with a patient and this patient passes away, there are many sleepless nights that I have thinking, what could I have done better? Could I have saved it? Or even if it is my friend who has treated a patient, the patient has passed away, I see they spend weeks ruminating about what could have gone different. So we've talked about the bystanders, we've talked about the patient, but what about a doctor facing his patient's death?
what advice could you give to that doctor, or if it's my friend as a doctor, what advice can I give my fellow doctor to deal with the death of this patient and the regret that consumes me?
Doctor, when young doctors come into palliative care, the majority stay on for life. They get a pleasure out of what they do. But there are some who become sleepless after the first week, taking every pain of everybody else. And then after 2 weeks, they take a week's leave and then send a resignation letter. It happens. Now, all of us go through this to some extent. We choose to be empathetic. We take on some of the suffering. And some of it, even though we want to leave it all back in the institution and go home, they will accompany us. Not every day, not every night, but it happens. And what we do is to be there for one another. Now, this is vitally important. Hari Prasad shouldn't have to take it all home to himself. We should be there to see his face and say, Hari, what's wrong today? Something is there. And acknowledging that may make Hari Prasad come out with what he feels, and once it all comes out, a problem shared becomes a problem out. That doesn't mean that it was all solved, but at least that somebody understands. It reduces his suffering most of the time. The problem occurs and cannot be easily handled about basically introvert personalities also going through the suffering. They will find it hard to share. And then they burn out. And what we can do is what you can do, doctor. What you can do is do this being there better than us. When somebody is going through that suffering, and maybe you may end up actually diagnosing depression, which we would all have missed, or even that the person is already has been living with a depressive illness, and you may be able to do the appropriate thing. Are we doing enough? No, we are not. But sometimes I have to go home and counsel myself, tell myself, Rajagopal, don't be a fool. You have tried your best. That's the best anybody can do. But then everybody cannot manage that. I don't have an answer to the introverts in the group who find it difficult to share and who burn out.
Thank you so much.
Good evening all. My name is Advait. ഞാൻ ഈ കോളേജിലെ ഫസ്റ്റ് MBBS സ്റ്റുഡൻ്റ് ആണ്. നമ്മുടെ ഇപ്പോഴത്തെ CBME MBBS കരിക്കുലം ബേസ് ചെയ്ത് we have this thing called family adoption program where we go into the society and we are assigned 3 houses, 3 families, and we go and meet them every once in a month, and we basically we learn from them and we give them whatever we can for the first 3 years of our MBBS. So ഞാൻ ഇതുവരെ 3 FABSs കംപ്ലീറ്റ് ചെയ്തിട്ടുണ്ട്. ആൻഡ് ഞാൻ പോകുന്ന ഒരു വീട്ടില് ഒരു അമ്മയുണ്ട്. ആൻഡ് 3 പ്രാവശ്യം ഞാൻ ആ വീട്ടിൽ ചെന്നപ്പോഴും ദിസ് വൺ റെക്കറിംഗ് തിങ് ദാറ്റ് കെപ്റ്റ് ഓൺ ഹാപ്പനിങ് വാസ്, പുള്ളിക്കാരി എപ്പോഴും ഇതിന്റെ കാര്യം, അയ്യോ മോനെ ഞാൻ ഇപ്പൊ പോകും, നിങ്ങൾ അടുത്ത മാസം വരുമ്പോൾ ഞാൻ മിക്കവാറും ഇവിടെ കാണില്ല. ആൻഡ് തൊട്ട് സൈഡിലായിട്ട് ഈ അമ്മയുടെ മരുമോളുണ്ട്. ആൻഡ് ഷീ വുഡ് ഓൾവേസ് റോൾ ഹർ ഐസ് അറ്റ് ദിസ് സ്റ്റേറ്റ്മെന്റ്. ദിസ് ഹാപ്പൻഡ് ഓൾ ദ 3 things that I mentioned. And I'm pretty sure this is a common thing that happens in many of our houses as well. നമ്മുടെ കൂടെയുള്ള elders ആയിരിക്കും ഇതുപോലെ പറയും, നമുക്ക് അത് ഇഷ്ടപ്പെടത്തില്ല. So what I see here is there are a lot of elders who are content with their lives, who have felt like they have done everything that they should, and all they wish later is a happy, peaceful death. But in the family, the rest of the family members, they won't accept it. They want their this particular person to live long. So when an instant comes when this said elderly person is in a life or death state and they put in say the ventilator, the family would want to keep them living for as long as they can. They don't even consider what this person in the ventilator actually wants. അവരോട് ചോദിക്കാൻ നീ പറയുന്നു നിങ്ങളുടെ അമ്മയ്ക്ക് നിങ്ങളുടെ അച്ഛനോ ഇനി ജീവിക്കാൻ ആഗ്രഹമുണ്ടോ അതോ do they want a peaceful death? They don't know and they don't care. The other person might just want to die peacefully as soon as possible without any difficulties, but the family members won't care. As I would believe, it is the living who make death difficult for the dying. So I believe awareness about death and end of life care should be given to the community. It should be given as a community awareness. But I don't see this happening. As far as I'm concerned, I haven't heard of any sessions explaining to the general public about end of life care and death of their family members. So I would like to hear your opinions regarding this matter and if such a discussion would be effectively possible in our society. Thank you.
They may have more to add. That's why first, I all admiration for your empathy. At this stage of your medical education, you get to know the person and feel some of their suffering. It's already in the curriculum. The implementation gap is usually huge in our country. You have end of life care officially in the curriculum. Some of it supposed to start with your foundation course and then conclude with your possibly elective posting during house surgery. Many things are yet to get implemented. This initiative by the and Arun and Alumni Association is a beginning. It's only a beginning. I hope it happens and I hope it helps people with empathy like you, both with the end of life care session and with the 8COM module, attitude, ethics and communication. There, that woman who is crying, you still do not know what makes her cry when she talks about that. I won't be here. I won't be here. She is scared, possibly. What she needs is someone without that person who is rolling the eyes. She needs to be heard. And she needs to bring out any fears that she may have in her. And once she brings them out, maybe things will become lighter. Maybe some of the fears are very often unnecessary. And it can be very real. Like a child who asks, won't I suffocate when they bury me? And this person may be fearing hell and being burnt there. Who knows? It needs to be brought out. But appreciate your empathy.
I'd like to get your opinion about two real life situations, taking a leaf out of advice question. These are two real life situations which I encountered as a young doctor. First with my grandmother, second with my father. Both of them died out of gastrointestinal malignancies. My grandmother at 88 years of age had symptoms suggestive of an intestinal obstruction, vomiting, things like that. She was taken to a hospital. Investigations revealed a huge tumor in the colon. She was operated. But once the tumor was removed, before the lymph nodes were effectively cleared, she had an arrest on table. She was resuscitated. And she was saved. Her life was saved. And the oncologist who was in charge there, who consulted my grandma, told me that it may not be feasible to do any further treatment, including chemo. She was very frail, fragile, and unable to pursue such things. So there was this discussion regarding breaking the news. And everyone was looking at me regarding how to do it, and I was the person who was supposed to do it. So what I decided was not to reveal this diagnosis to my grandmother. I'm asking you your opinion regarding whether what I did was ethical or not. Because she was always petrified about cancer. She was discussing about some of her relatives, neighbors, etc., dying of cancer, going to RCC and things like that. So at this stage, when chemotherapy or radiotherapy, nothing else is feasible because of the frail nature of her physical health, I decided against revealing that diagnosis. She lived for another 5 years and at the ripe age of 93 years died because of a cardiac problem. And the second issue was with my father, who was diagnosed to have gastroesophageal junction carcinoma at a very early stage. He went through a surgery and then chemotherapy, and unfortunately had metastasis. It was at that stage was another decision had to be taken. So there again, my oncologist friend told me that there is nothing else which can be done at this point of life to save his life. So the diagnosis was revealed to him. I got him discharged from the hospital, took him to home, and again the issues which relatives raise already, all the relatives, cousins, and so many neighbors also were asking me why you are keeping your father at your home. Why don't you take him to the big super specialty hospitals? So there again, I took a decision, and my mother thankfully concurred with my decision. So we took a decision, and we decided not to bother about anybody else. I held his hands, and he passed away at midnight on the 13th of March, 2014. And I felt fulfilled at the end of that incident. That is what I feel. So I'd like you to give your expert opinion about these two acts which I did as a human being, how ethical I was as a human being, as a doctor, as a son.
About your grandmother. So glad that she could have 5 good years. Oh my God, that's such a blessing. It turned out to be a blessing. It need not have it like this. The points in favor of finding out whether she wants to do it, whether she harbors any unrealistic fears. In this case, obviously, she did not. But some people fear the worst, which may be worse than the reality. We can eliminate that fear. Some people may have clear agendas, like we disclosed the diagnosis of ovarian metastatic cancer to a 23-year-old girl and a 26-year-old husband who had been married only 3 months back. And then they took 3 days to decide to accept chemotherapy, but said not this week. From the day they got married, the girl had been asking to go to Ooty. And they decided first they will go to Ooty, have 3 days there, then come back and he gives the chemotherapy. So people may have their own agendas that need to be fulfilled if possible. But what worked was the best, obviously, in this case. We all have, I am sure everybody will be happy, feeling happy about your grandmother. And about what you decided. I feel like shaking your hands. This is what we tell children of patients. After all I suppose Ms. Archana must be doing the same thing. After all the conversations, we'll tell people, one thing, let us have it very clear in your minds, that you will do the best for your dad, not something to please somebody else. Because people will keep asking, very difficult comments will be made. എടാ നിനക്കിപ്പം നിന്റെ സ്വന്തം തന്തയല്ലേടാ, നിനക്കിപ്പം അങ്ങനെ വേണ്ടി കാശ് ചെലവാക്കാൻ വയ്യല്ലേ, ഇവിടെ ഇട്ടേരെ, ഓണിൽ ഒരാളുണ്ട്. Such barbed things they may say. So we have to prepare the son and daughter to smile and just ignore those comments, which is exactly what Arun did. And the anniversary, right? 12th anniversary today. So we all share your grief, but also your happiness on having achieved something great.
Thank you, sir. Yeah, there is a question there.
Good evening, sir. My name is Sumitra. I'm a first year MBBS student. And my question might actually be basic because I have not yet been exposed to any clinical conditions. Any clinical knowledge I have is from textbooks only. But I was just curious to know what happens when the life of a person is weighed against their financial conditions. Like ഒരു പേഷ്യന്റിന് മരിക്കാൻ അവർക്ക് ഇനി നോർമൽ ആയിട്ടൊരു തിരിച്ചു വരവില്ല. ട്രീറ്റ്മെന്റ് കൊടുത്താൽ ചിലപ്പോൾ തിരിച്ചു വരാം. പക്ഷെ ആ ട്രീറ്റ്മെന്റ് കൊടുക്കണം എന്നുണ്ടെങ്കിൽ അവരുടെ കുടുംബം വിൽക്കേണ്ട സിറ്റുവേഷൻ ആണ്. സോ അങ്ങനെ ഒരു ഓപ്ഷൻ ഫാമിലിയോട് ഡിസ്ക്ലോസ് ചെയ്യണോ? ചെയ്യുവാണെങ്കിൽ ഹൗ ഷുഡ് ബി ഡീൽ വിത്ത് ഇറ്റ്? That is my question.
Sorry, what's your name?
Sumitra.
Sumitra, first year medical student, and you are asking such a brilliant question. Wow.
Thank you.
Again, I am doing all the talking. Sumitra, into whose life is it? It's that person's. If he wants to know what options are there, we have to let him know. But sometimes it can be cruel to tell him, well, there is a medicine which would cost 3 crores every 3 months, but that is generally medicine has to be imported from USA. What do we achieve by saying that to the person? We have to give them the realities. Like, sometimes it may sound cruel, but I don't know whether we can always give the percentages and whether that is wise. But if we know it, there is a small percentage that spending 88 lakhs may cure the disease. But I must tell you, the possibility is small. And knowing that seems to be is the person's right, and we do not have a right to conceal the fact. But you will also tell them, don't take a decision right away. Go home, discuss with your family. Whether you have that treatment or not, we will be with you. We will continue our support to you. We'll also talk about what other options you have. Then also we will offer. But the person has a right to know. Right to know realistic options.
Just a follow-up question. In this case, if the patient is hearing all the options and he or she is willing to just move forward with her natural conditions, no treatment, but she doesn't want to tell about the treatment option to her family. Because if they know, the patient thinks that they will try their best to have her survive. So she omits the treatment option when talking to her family. Is that ethical? As a doctor, should you support that?
I don't know. If you have a difference of opinion, you must point it out. But Sumitra, primarily, your primary responsibility is to the person. You have a responsibility to the family, but that doesn't override your responsibility to the person. And if he says, okay, doctor, this is between us, please don't tell my family. And if then the wife comes and asks, doctor, what's happening? He says, I have discussed in detail with him. And he is the kind of person who likes to handle everything himself. Please talk to him. And we may have to leave it at that. But don't take that decision as final. Maybe we'll also tell him. But if she doesn't know, imagine the kind of anxiety she will be in. So please think again and we'll talk about it next time.
Thank you, sir.
100% I agree with what you have told, sir. Because medicine or medical expense and modern medicine, to be precise, happens to be one phenomenon which may lead to damage to the family even after the person has exited from the world. We need to be aware of that. Health economics, again, something which we have to study as part of our curriculum, but unfortunately, not emphasized. So there is an expert in health economics also, maybe in another session he may talk about the expense for healthcare, because there is something called out-of-pocket expenditure for healthcare. Now, for every single person living in Kerala, per year 13,000 rupees plus is being spent. Government is spending 4,500 rupees, while the people are spending 8,700 plus rupees per year out of pocket. And even though Kerala happens to be the state with best health indices, unfortunately Kerala is the state with biggest out of pocket health expenditure. It's a very important thing which we have to take into consideration. So hats off for bringing up that issue so that we could discuss that also. Maybe we'll discuss the details and nuances of that in some follow-up session. So here, like what Sir has told, the legal aspect of that also. There is only one disorder or one condition in which we need to take into consideration the interest of the caretaker and not the patient, which is that the illnesses which we treat probably, mental health disorders. A small section of mental health disorders, I would say, not all. Those disorders called psychotic disorders in which the person does not have any insight about this condition. And there are only probably a few illnesses for which there is a legislation in place, and one of them is mental health. There is a Mental Health Care Act 2017 which specifies this. There is a section 86 of that act which says that if a person has insight about this condition, he can voluntarily come for treatment, he can request for admission, and he can request for discharge once he feels he is better. But there is another section called section 89, which applies to those conditions in which the person does not have any insight about this condition. He's too psychotic to understand his own condition. He's creating disruption to the society, he's trying to end his life, he's assaulting his family members. Those specific conditions, section 89, is the caretaker, the person, the relative, can request for an admission. Of course, there is a legal procedure for that. Even if you admit such a person, you have to inform the admission to something called Mental Health Review Board, which is present in every district. And they can come and inspect you to see whether the admission is on genuine grounds. Or have you just admitted the person because you have been influenced by the caretaker to make him mentally ill. Such possibilities did exist in the past also. So it was a wonderful, wonderful question. Hats off to you. So we are coming to the, yes, please.
So my name is Jubilee. Like my experience in the life, like one of the first death experience. Like in the neighbor, I had cancer. So like our cancer treated. Family support ആയിരുന്നു കുറെ ആൾക്കാർ ഫൈനാൻഷ്യലൊക്കെ സപ്പോർട്ട് ചെയ്തു അങ്ങനെ അത് ട്രീറ്റ് ചെയ്തത് കുറച്ച് ആൾ കഴിഞ്ഞ് അത് മെറ്റാസ്റ്റേറ്റ്സ് ആയെന്ന് തോന്നുന്നു വേറെ എവിടെ ക്യാൻസർ വന്നു ലൈക്ക് പിന്നീട് ഈ ഫാമിലി മെമ്പേഴ്സിന്റെ തന്നെ ലൈക്ക് ആ ആളുടെ വൈഫും ചിൽഡ്രനും തന്നെ ഒരു എന്താ ആളൊരു അവോയ്ഡ് ചെയ്യുന്ന ഒരു കേസാണ് കാണുന്നത് ലൈക്ക് ആളുടെ അടുത്ത് ഭയങ്കര ദേഷ്യം അത് കാരണം ഇതൊക്കെ കാരണം ആൾക്കും ഈ വൈഫിന്റെ അടുത്തും ചിൽഡ്രന്റെ അടുത്തും ഭയങ്കര ദേഷ്യമായിട്ട് ഉണ്ടായിരുന്നു ലൈക്ക് ബാക്കിയുള്ളവരുടെ അടുത്തേക്ക് അത്യാവശ്യം നല്ല രീതിക്കാണ് പൊയ്ക്കൊണ്ടിരുന്നത് അങ്ങനെ ഒരു ദിവസം ആൾ ആക്ച്വലി വേദന ഒന്നും സഹിക്കാൻ വയ്യാതെ ആള് സൂയിസൈഡ് ചെയ്തു സോ അപ്പൊ ഈ ഫാമിലി മെമ്പേഴ്സ് ആളോട് കാണിച്ചതിനെ കുറിച്ച് എന്തായിരുന്നു അഭിപ്രായം?
Vivek, thank you. Vivek, we are not angels. We are human beings with our own weaknesses. We will have to go through difficult situations, and we keep finding burnout among family members. So, Vivek, when you, I don't know if you ever have headaches or something, when you are not well, when you are hungry, you have had to miss a meal, do you find yourself a bit irritable? When you are, somebody else is nodding, yes. When you are a bit irritable, who do you show the irritation to? Not to him, not to Dr. Devika. You will show it to somebody close to you. Majority of people choose their spouses, or better still, children. Same one. അവൻ തിരിച്ചു തല്ലില്ല. This is human nature. And when that family member, I don't know whether you, in your mind, you consider them at fault. I won't. I'll be careful not to be judgmental about them. Maybe they are not getting sleep practically no night. They've been losing sleep. There's no money. This man has borrowed money, and then all the debtors are coming and asking the wife. They will be under their own pressures. We don't know what's happening. And gradually, you keep lashing out. You kind of think that conversation is the only thing that happens. They feel emotionally farther and farther apart. Unfortunately, this happens quite often, certainly with mental illness, certainly with major disabilities which cause lifelong suffering, and that's not uncommon. What you and I can do is to sit with the person alone and ask, I see that you are very impatient with some of your conversations with family. You are angry about something inside. Would you like to tell me about it? And then you will ask the same thing to the spouse or to the child. And then you will hear both sides of the story. Sometimes, only sometimes, you are able to get them together. And maybe at the end of the conversation, they may hug each other and cry. That's a good outcome. But very often we may not succeed. It may be personalities, it may be a husband and wife who have had a great difficulty living together for the last 33 years. And sometimes this kind of thing does happen. But this person happened to kill himself. That means he must have been going through so much of suffering that if it had got to his attention, he could have easily made a diagnosis of a certain mental disorder. Maybe he treated it. That also happens. Up to 33% in one study, maybe not in every group, of people with cancer were found to have clinical depression, at least for some time during their illness. And in their own department, they came and did a study on people with disabilities and found the incidence of depression up to something like 17%. So these are undiagnosed issues which cause suffering. And I wish all of us, once you learn a bit of palliative care as part of your medical education and you learn to practice, you may be able to solve some of these problems. But many, we may never find out.
Just to add to that, what's mentioned, I was mentioning about Elizabeth Kubler-Ross's book on death and dying. Says that if a person is diagnosed with a serious illness, there are 5 stages through which his frame of mind goes through. Immediate reaction, number 1, is denial. I'm unlikely to have this diagnosis because I was a teetotaler till this stage. And my school classmate who is drowning in alcohol is walking around without any problem. Then how come I get this diagnosis? It should be wrong. That is denial. You take second opinion, third opinion, opinion of ChatGPT, Google doctors, and so many such things. It goes like that. Second is the stage of anger. The patient will shout at the nearest possible person, like Sir mentioned, the caretakers. If he's in the hospital, he may shout at the doctor. He may shout at the nursing staff there. That is, of course, understandable. It is the reaction of a helpless mind. It is not out of animosity towards you. The third stage is the stage of bargaining. Will I live long to see my daughter's marriage? Will I live enough so that my son becomes employed and my family becomes well settled? This bargaining will happen towards doctors, towards the entire treating team. He'll ask this question to the professor who is heading the treating team. Professor reassures him. Then he'll ask it to the house surgeon. It doesn't mean that he doesn't believe the professor, it is again the reaction of a deceased mind, or distressed mind, I would like to call it that way. So that is bargaining. He may bargain with God also, even if he is a believer. I will do these kind of things if you allow me to survive for 2 years. Then comes the fourth stage, that's the stage of depression. It is exactly in this stage that people kill themselves. So it is important to identify depression in cancer patients. Like Sir told, 33%. Certain cancers like pancreatic cancer, as high as 90%, because it's one of the most painful cancers around. Pancreatic cancer and brain tumors, these are the two conditions in which depression is around 90% in prevalence. Finally, the fifth stage, that is the stage of acceptance. You accept the reality that you have only so much time remaining as per the scientific knowledge available. How should I enhance my life or add life to my remaining days? That happens to be the philosophical position at that stage. So our duty as a doctor is to take the person right from the first stage to the final stage at the earliest and minimize the fourth stage, that is depression, to the shortest possible. And again, a word also, the kind of reaction which the caretakers have been taking to this person, call it as expressed emotions. Expressed emotions are a group of powerful emotions which any caretaker exhibits towards a person with a chronic illness or a disabling condition. Essentially, 3 types of expressed emotions are there. Number 1 is overprotection. You don't allow him to go out and mingle with others, even eat an ice cream, which Sir was mentioning. Second is critical comments. Critical comments means they always tell that my life has been ruined because of your illness. I'm unable to go out. I have to take care of you. I don't have a social life. I can't go and watch a movie. Critical comments. And finally, third is hostility. You deprive him of food. You lock him up in a room. These things happen most commonly with mental illnesses, but with other illnesses also. But there are 2 more expressed emotions which are positive. One is warmth. Express your emotional warmth to the person by hugging him, expressing your affection whenever possible. Again, you are also a human being as a caretaker. Cannot afford to do it always, but try to do it as much as possible. And next is positive reward. The person with the illness, when he does something to help you, some household chores or something, please appreciate him for what he has done. These 2 positive expressed emotions may help him come out of depression to a certain extent. So that's the theoretical aspect of that. Thank you very much. Yes, Pranav is telling something, please.
First of all, I'm very happy to share this platform with my mentor, Dr. Arun sir. Rajgopal sir, I have to say one word about you. I'm senior resident of psychiatry department. So I have met you in 2019. You were our chief guest in convocation while I was a UG student in Thrissur Medical College, 2019. So palliative, my interest with palliative principles started probably during my first year MBBS days as these students. I was a part of a charity wing in our medical college, you might know, Solace Punarjani, running in Thrissur Medical College. So I would like to share a personal experience. I do not have any queries because beautifully they have answered all the queries, and I'm proud that my juniors are raising such brilliant questions. So my personal experience is about my dad, as Arun sir has also mentioned. He's comfortable, healthy as of now. He has done a bypass grafting, coronary angioplasty and bypass grafting. He is taking care of his elderly parents, my grandparents. So I am basically from a family in Palakkad who believes in such sort of things like spirituality, taking care of elders. Sometimes it crosses the barrier, the line between our peace of mind and theirs. And we often engage in some small struggles. I have been seeing this pattern in the family, entanglements of sufferings. So here I feel the importance of death education. I feel this session my father should witness because he has been, from the moment I have been seeing him, in a constant pressure of making his elder people live and live, keep on living. And he has been in that constant pressure. So I have been able to impart some of the principles. So I feel that what Advait has raised is right. We need death education. We need principles of palliative psychiatry, psycho-oncology in our UG curriculum as well as in PG curriculum of all specialties. We do not want more super specialty hospitals. Yeah, that want them to, but apart from that, we need more sensitive, empathetic doctors who know some principles of all these aspects, because upcoming era is of soft skills and of empathy. Without selective empathy, or at least cognitive empathy, we cannot survive. Again, the other part of the thing which people have raised here, burnout, moral injury have been inclusions in ICD 11 already. So we should be also able to safeguard ourselves from all these moral injuries while dealing with all these kinds of deaths. That is my take on the thing. So it was a wonderful session where science met philosophy and spirituality. One of my friends, I remember, cherished her, Dr. Nida from my own MBBS batch. She was an ardent fan of you, I think, Rajagopal sir. And she would always have this ambition of taking some course from Pallium, and she has done her course in palliative care. Her name is Dr. Nida Apurugapur. Still, I remember those days with her when we spent evenings in Thrissur Medical College dispensing the medicines as a part of Punarjani, which was our charity wing, as a part of Solis, in collaboration with Solis. That's it.
Thank you very much, Pranav. And a word about Rajagopal sir's two books mentioned at the beginning. Two wonderful books written by him, which is available at the back of this counter. I would request you to buy these books. Number one is Walk with the Weary, the life-changing lessons in healthcare. This is book in English. And second book is the Malayalam book Sneham Sandvanam. വേദനിക്കുന്നവർക്ക് ആശ്വാസമായ പാലിയേറ്റീവ് കെയറിലെ ചികിത്സാ അനുഭവങ്ങൾ. These are experiential accounts of his rich, fulfilling life as a palliative care physician. And the money you pay to purchase his books is going to Pallium India's activities. And Pallium India is running a wonderful course also called Global Fellowship in Palliative Medicine. Dr. Devika did that course recently and passed out that course also. So whoever is interested in that course, please join that course. Definitely you are going to be enlightened a lot. So I think an online
the question, we got an online question from the live. Some volunteers, non-medicals from the community say that they understand the theory about death, but find it difficult to accept loss. How can this be helped? How can we condition the community?
To 1978 Alma Ata Declaration, which the community medicine people will remember at least, that the community should be part of healthcare. Healthcare cannot be done by healthcare professionals alone. Mr. Anifar Author knows this very well. It requires agriculture, food, industry, transport, everything has to come together if the person is to get to you. The community has to be engaged. The neighbors used to be engaged at one time. They can do harm also. That's also true. But not anymore in the modern nuclear life. We know that the community can help. 40 years later, Astana Declaration said, we give some control over healthcare to the community. That's why we have so many volunteers helping us at every step of the way. And they are there to make sure that the person eats, which I, as a doctor, may not even find out whether the person is eating. So the community needs to be engaged. What the question tells me is that the education that we now give to community volunteers, especially in communication, is not enough. Even for doctors, 6 weeks courses, eventually the feedback is they feel a bit confident in symptom control, but not in communication. So we'll together have to work out how to fill that deficiency and make it more efficient.
Thank you, sir. As was suggested by Advait and you had reiterated, we need to conduct more end-of-life education programs, and hopefully after your first year MBBS exam is done, we may hopefully organize a medical exhibition related to palliative care. And we will dedicate a section on this topic. And we will definitely invite Sir, Madam, Hariprasad sir and the entire team of Pallium India to do a workshop for the common public, not for the doctors. And we would also learn a few lessons from that. So with these words, the time is already 7 p.m. and it's time for dinner. So I'm extremely thankful to the entire audience for remaining and actively participating in this discussion till now, especially to the youngsters, Rajesh Bhaiya for his repeated questions, Advait, Sumitra, and the youngsters in particular, and all the people who have contributed. Thank you very much for your very patient listening and active participation, and my sincere gratitude to Rajagopal sir, Parvati madam, Hariprasad sir, and most importantly, our young friend, Siddharth, for enriching this discussion with your valuable insights. So over to the MCs for concluding.
Indeed, what a rich and deeply moving discussion this has been. On behalf of all of us here, I extend our heartfelt gratitude to Padma Shri Dr. M.R. Rajagopal sir, Dr. Parvati Sundaresan ma'am, and Dr. Hariprasad sir for your wisdom, your compassion, and for reminding us of the immense responsibility and privilege that comes with caring for another human being at the most vulnerable time of their life. May the words shared today find a permanent home in how we practice, how we teach, and thus how we live. We now arrive at the conclusion of this program. To offer the vote of thanks, I invite Dr. Pratap Mohan sir, convener of the Platinum Jubilee Celebrations Committee of GNCT. Please join me in welcoming Dr. Pratap sir.
As we come to the dying moments of this program, we have an end of ceremony or end of the program ceremony that is generally not ideally looked forward to, or it is usually something that you have to sit through. The vote of thanks is probably a formality that is done for the sake of it, but today it was an excellent session, and any kind of gratitude I'm expressing here is coming from the heart, because I did not expect this to be so interesting or so meaningful. I come from a department that is pathology, where many decide to go into pathology because they don't like breaking bad news. You go into pathology, see, you have the sadistic pleasure of making the diagnosis and not telling it to the patient. So from a department like that, people who are afraid of being in this position, to being told about what or to be given an idea of how to face such a situation, it was really, really eye-opening for me. I have to go through this fast. This is, like I said, not something that we should be spending too much time on. First, all three panelists, Rajagopal sir, Parvati madam, Hariprasad sir. When you say it's a panel, it's a panel of experts. Sometimes it is a superlative. Sometimes you feel that they're not really experts. But when I first saw sirs, and I know Hariprasad sir from before, but when I saw sir and madam, Rajagopal sir and Parvati madam come in, they were both so simple, polite, and meek. And when they started answering questions, they were in some other zone altogether. It was like Sanju Samson in the last three games. They were experts. You could see that they knew what they were talking about. So that is why I felt that this was an excellent session, because we have the real proper people who are dealing with this topic. I really don't know why I am here, because when I was sitting in the inaugural ceremony, that is when I came to know that I was organizing secretary. There is a very good thing about being with Devika and Arun sir. They will do all the work, and finally they will give the credit to someone who is standing somewhere around. So I came to know that there was a program like this 3 days back, and Arun sir asked me to circulate it. So that is all I did as organizing secretary. I put this in a few WhatsApp groups, and so whom I should really be thanking Arun sir and Devika for the plan, the execution, everything that's been happening here, the invitation of everyone,
and also the team from Pallium India who are behind this entire program. Lots of students, Siddharth on the dais, students off the dais, Advait is still here, Rajesh, I think he's left. There are lots of students who contributed. It is with a tinge of jealousy that I see this. When we take classes, we don't get this kind of response, but at least when we see it, sometimes it's happy. I hope you do this more. And there are a few people, generally it's better not to name, but there are a few people to name that I would be doing an injustice if I left out. That involves the venue was prepared by Balin Jetton from gardening department. The sound system was prepared by Shaz Jetton. And it was a challenge to get tea and snacks because, as we all know, there is a war, there is no LPG, there are no places we can order from, and it was Satish Canteen that helped us here. SAT also helped us with the digital broadcasting center, the team Vinu and team from DBC who have been covering most of our programs in our platinum session. And so probably in addition to that, because it's all SAT Supran Bindu was also here, so a vote of thanks to you too, ma'am. So I may have missed out on a lot of people, but very happy, and I'm very sure you're also happy that you were part of this event. It is something that was really valuable for me, and hopefully it was for you too. All the seniors, Sundareshan sir, Vilasni ma'am, Ghosh sir, everyone who's involved here, thank you all very much. There are times when you are lucky. I would have missed out on the most important person, and then he walks in. So it is like a reminder. The person who inaugurated our function and the person who is behind this whole monthly, or right now it's becoming fortnightly programs related to the 75th Jubilee of our college, Jabbar sir. He has the enthusiasm of first year medical student, and he is a live wire who helps us come up with this. We are all നമ്മളെ കൊണ്ട് പണിയെടുപ്പിക്കുകയാണ് എന്ന് തോന്നിക്കില്ല. സാറ് പണിയെടുക്കും, നമ്മൾ പണിയെടുക്കുന്ന പോലെ അഭിനയിക്കും. Jabbar sir, Usha Devi ma'am, she has also been instrumental in making sure that we will conduct each of these sessions regularly. In his absence, Vishwanathan sir, he has always been supportive. He was here. He should have been here as to inaugurate, but being a DME, time is usually not in his hands. So, in the absence of Vishwanathan sir, I thank him too. If I've left out anyone, please pardon. I've taken more than enough time than one should for a vote of thanks. So, thank you.
Thank you so much, sir. As we close this evening, let us carry forward the spirit of this gathering, a resolve that every patient in our care, at every stage of life, and at the threshold of death, shall be treated with compassion, dignity, and love. Because everyone, truly everyone, deserves a dignified death. Thank you all for being here. Kindly rise to the national anthem.
Just a minute, I'm sorry. Two names I forgot, Vibha and Sharda. They've always been with us for our programs. They are real MCs. So thank you.
Yeah, the national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा नव शुभ नामे जागे नव शुभ आशीष मांगे गाहे नव जय गाथा जनगण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Stop streaming. Stop streaming. Kodutana.